Well, good morning. I'd like to call the PCPID meeting to order. I am Jim Brett, and I am the chair of the President's Committee for People with Intellectual Disabilities, often simply called the PCPID. This is day two of our two-day meeting. Yesterday, we accomplished a lot, and here are just a few of the highlights. We reflected on the outline of the 2024 PCPID report, which is focused on HCBS. We anticipated the report will be released very, very soon as it undergoes its final review for technical accuracy. Both PCPID citizen members and members of the public had an opportunity to share barriers they observed of the IDD population in their community. We were briefed from academic scholars on the latest disability statistics. We were briefed from several lawyers of recent HHS regulations implemented to help further advance disability rights and equity. And then finally, we were able to swear in our newest member of PCPID, Emmanuel Jenkins, from the great state of Delaware. Yes, I agree. We covered a lot of ground and probably too much, and in the limited time we had available together. And I understand several members took the time to reflect on yesterday's proceeding over dinner last night to further digest what was shared. Today's meeting agenda focus will shift away from surfacing the barrier themes to an increased focus on addressing the barriers in the road ahead as we launch into the new fiscal year starting next week. Today, we seek to accomplish the following: to hear from PCPID citizen members about barriers they observe in their communities, learn from different federal agencies about initiatives they adopted to support the intellectual disability community, learn more about innovative ACL health equity initiatives, learn more about innovative advancements in technology to improve service delivery. And then finally, we would like to close today's meeting with identifying maybe 4 or 5 particular topics we may wish to explore in the new year. Please know we adjusted the agenda today to ensure there is more time for dialogue and engagement with each of the panel presenters. We know that this is very important to the members of the committee. And at this time, I'd like to pass it over to our meeting facilitator, Robin Levine.
Thank you, Chairman, and good morning to everyone. Quickly, some housekeeping items, same as yesterday, and a couple of new ones. This meeting is being recorded. We do have an ASL interpreter and CART for this meeting. If you are joining us as a public member, you are in listen-only mode. We appreciate that you have joined us today and showing us your interest. People from the public are joining us both in the room today and through our Zoom webinar. For our PCPID members, we have members here in the room with us. We also have some members online. If you're joining us virtually, your microphone is muted to prevent background noise, but if you have a question or comment, please raise your hand virtually, use that hand raise icon, or enter something into the chat, and our project team will help me to know that you have a question or comment to make. As the chairman said, we have adjusted the agenda today, so things are not going to necessarily appear in the order of the paper that you have in front of us. And yes, we are going to have more time for conversation, maybe still not quite enough time. So I'm going to do my best to make sure everyone is heard, but I will still be keeping very clear time markers and reminding folks when we need to move to the next topic. So with that, thank you. And as Chairman said, we're going to finish what we started yesterday, which is to hear from the remaining PCPID citizen members on the one leading barrier that you are observing in your community that impacts people with intellectual disabilities and their families. So If you would let me know, Wanda, is Gabriel Martinez on the line? Gabriel, are you with us this morning? All right, we'll wait for Gabriel to join us. James Meadors, you're here with us in the room. I know that. James, are you ready to share a barrier with us? Okay, James, take your time. Lucy, how about you? Are you ready for us? You ready to go?
Yes.
Thank you. And you know what, seeing that microphone come forward, if everybody would please try to have their microphone as close to your face as you feel comfortable, so that we're sure we can hear you. Thank you. All right, Lucy.
Oh, okay. My name is Lucy Meyer, and I am very, very honored to be here. One big problem I faced when I was younger was when I went to school. I went to three very, very, very good schools. But then when I graduated high school, all my friends kind of left me, and there was really no place, no longer a place for me to go, because all my friends kind of just left. But then we found Special Olympics and Birth Buddies, and because of them, I was able to make many, many, many new friends, and was able to make make new friends and communicate in that way.
Thank you, Lucy. Just making sure you have finished your comments. Yes?
And I was just very grateful to have that kind of an opportunity, because I know a lot of people don't get that. So I want to make sure that they're able to get that same thing that I was able to get, because it was so great.
Thank you, Lucy. Thank you very much for sharing your comment. Thank you. James, don't want to rush you, but are you ready?
Yes.
Okay.
Thank you, committee members. Before I start speaking, but I want to say that I'm the original person, say I am the person voice of reason. But someone took that line away from me. And they say they are the voice of reason, but we are the voice of reason. I feel like we have a major crisis who are frontline workers who we do not know are having a terrible time taking care of their health. We know we have a national organization talking about frontline workers and try to get better legislation. But at the same time, some of the frontline workers do not know these organizations or what they are doing. In Texas, in the frontline workers in the small and pop provider agencies are facing many challenging issues. We need to focus on these small agencies. It's nice to have who are big in the field, but but sometimes we forget the small and mom pop or agencies. The small agencies get funding from the local DD agency. It is a challenging issue for mom and pop agencies because the frontline workers' rate of pay is generally low. Then the bigger agents can pay health insurance, 401ks, or usually not offered by the mom and pop agencies. As the mother of a pop and also the mom and pop agencies do not offer paid time off, or sick leave. Even self-directed services by people with ID intellectual disabilities usually do not pay healthcare needs to frontline workers. It is a disservice for the worker I know, V, who is really good at her work and skills, has a caring heart for people that she is supporting. She works several small providers in order to have enough work to pay the bills. She just missed 1 week of work because some of the people she worked have COVID-19 and she got COVID-19. We did not get paid for that week. She buy health insurance through the healthcare gov. But missing that week of work pay caused major issues for V and her son living with her. They are tackle his health issues. She had to go to Fund Me page. To make paying rent, buying groceries, and getting health insurance. I'm going to repeat again. She had to do a GoFund page. It's a disservice that frontline workers have to do a GoFund page. And like I said, she had to buy groceries, get healthy medicines. Free works like myself are considered as lowest of low. If we want the benefits, we basically need to be a nurse. Not only would we receive the benefits, but we would get more pay. I don't want to be a nurse. Otherwise, I would have gone to school for that. Frontline workers do most of the work and some of the work all the time, just make ends meet. V knows that she cannot work like crazy and stay healthy, but she works from 9 a.m. to 7 p.m. or even 8 p.m. During the week and 11:30 to 10 on Saturday, and she still tried to make ends meet. She says she feels lucky to have friends that could help her, but she knows other frontline workers that are even worse situation. This is why we need to do a better job of supporting moms and pop agencies providers. As committee members, I would love to get our foot in the issues and get to know individual states and their powers like that. To set executive action order or policy, oftentimes parents or people with intellectual disabilities do not know who we are or advocate for direct support workers, especially small and pop agencies. If you ask a group in small Texas what the president's committee is, they would not know what it is. Because they didn't know what the president committee is or even know what it does. And part of me, I shared yesterday, APS, is how we could do a better job to help people with ID when they take advantage and do investigation to help that person. not pick and choose which ones is most important or least important. And also, I want to get more people out the institutions because it's sad that our state in Texas, we have 13 institutions. The last time they closed 2 institutions by a court order, not a state order. We need to close more institutions in Texas. Thank you.
Thank you very much, James. Thank you. Nick Perry. Nick, are you with us in the Zoom meeting room? Nick Perry?
I am sorry. Can you
Wanda?
hear me?
Yes. Good morning.
Good morning. My apologies to the committee. I'm currently addressing some hurricane-related flooding here in my home, so I have nothing to share at this time. But I'm present and listening intently.
We're sorry. Be safe. We're sorry. Hope everyone and everything in your life is safe.
Thank you.
Hillary Stannis from Massachusetts. Are you in the Zoom meeting room with us?
I am.
Good morning.
Good morning. I'll be fairly brief because I don't, a lot of what I would say has in a sense already been said, so I don't want to take time just to take time, but just quickly, I'm from Massachusetts, just like Chairman Brett is where I am. Cost of living is quite high here and an issue just like it is in many other states. So a pay rate for DSPs or other frontline workers, even if it's 16, 17, 18, 19, even $20 per hour, it's just not really going to allow that person to make ends meet, like James was talking about. But it's also really not enough to be competitive with even fast food chains, Starbucks, Target, jobs that are requiring significantly less skill or they don't really have to take on nearly as much responsibility. I am on this committee really in my role as a sibling. My older brother has Angelman syndrome. Because of the Angelman syndrome, he has very high support needs. He's has very limited kind of functional communication. He's non-speaking, and just is a gentleman who has very high support needs. He's a wonderful person and is loving and happy and just a wonderful guy. But I do also happen to be a lawyer at our state's protection and advocacy agency. So, I can't help but bring that, what I see through my work day in and day out to help inform my thoughts of what's going on in our community here and in our state. And I also just, since I've been appointed to the committee, became, mom of a young child who also has medical complexities, but is also a member of the IDD community. So lots of different frames of reference and places to gather some perspective from. So at the end of the day, like the workforce crisis and shortage of DSPs and other frontline workers, I really think is the root cause of pretty much every issue or challenge that the IDD community and allies and family members of the same it's just the root cause of all the issues that we're facing, whether it's waiting lists or, unfortunately, like both from a family member experience and from my work, abuse and neglect issues. I've seen stats as high as 9 out of 10 people with intellectual and developmental disabilities will be abused in their lifetime. And again, you dig into that and the root cause comes back to, do we have a trained, competent, appropriately compensated workforce who's doing, the work for the right reasons and has the skills and tools and supports to do that, and also makes enough money that they don't have to do 3 different jobs and are absolutely exhausted when trying to, implement a complicated behavior plan or something. It's just a recipe for disaster. Also in our state, unfortunately, a lot of, what we see because of the workforce shortage is, the struggle to really get like basic needs met. So, we have a lot of people with the really highest level of needs, whether it's kind of ADL, medically, behaviorally, some combination of those, are often the people waiting for services. Now, in this, maybe they attended a, program of some kind, had services pre-COVID. We see this a lot in the like day/work program context of folks that attended there, pre-COVID, and then they're still waiting to return, even though the people that maybe have less support needs and less intense staffing needs, so a staffing ratio could be less, that group is, provider agencies are having them return, and not so much the people with the highest support needs. While certainly have concerns about that being like somewhat discriminatory, but the root cause is they don't have sufficient amount of staff working in the agencies to really be able to serve all the people that they're trying to serve. And the people with the highest needs, far too often in our community, are being left behind, many of whom live with aging caregivers, unpaid caregiving family members. And it's just a really hard situation to see in my, own personal experience and through the lens of my work and seeing the struggles of other individuals and families.
Hillary, excuse the interruption, but we're going to have to ask you if you could come to your conclusion at this point.
Sure. And I said I wasn't even going to talk that much. So and that's all I had to say. I just, obviously, like many of us, could talk about this topic for so long because it's frustrating.
We understand.
So thank you very much for the opportunity. I appreciate it.
Thank you for your kindness. Thank you, Hillary. Thank you. All right. So I realized, because some folks spoke yesterday, and if you're trying to see what order you're going to speak in, I'll try to prompt you. So we're going to go to James Trout, and then from James, we're going to go to Emmanuel Jenkins, and then we'll come to Jordan, and then we'll see if Gabriel Martinez has joined us. So with that, James Trout.
Yes, I'm James Trout. I've spent the last 5.5 years working in Northern Virginia for a nonprofit called Source America, whose mission is basically the same as PCPID's, which is to get people with disabilities employed as much as in gainful employment and to maintain gainful employment as much as possible. To sum up, basically my life experience, I was diagnosed with what was then called Asperger's syndrome, now would be called autism level 1, when I was 15 years old. Despite that, and despite having called and having moved around a lot growing up, I've called 7 states home in my life: New York, Massachusetts, Maryland, Vermont, Pennsylvania, Delaware, and Virginia, plus DC. I did manage to obtain both a BA in political science from American University and a master's in transportation policy from George Mason University, and maintain and been given gainful employment and the ability to live independently from my family. I realize, however, that I'm very much one of the lucky ones, and I say this, and I take no glee in saying this, but and that people in my situation are unfortunately the exception rather than the rule. And but while the situation on disability issues has changed quite a bit since my diagnosis, when I was first diagnosed, I was the first person in my high school to have been given a diagnosis, who had been diagnosed with Asperger's syndrome. My high school in South Burlington, Vermont, where I was living at the time, did not have a clue on how to deal with it. In the past quarter, roughly 1/4 century, though, things have changed for the better, but we are still a long ways away from obtaining a journey where it's even close to being at acceptable levels. I'm proud to be in this community, and I'm proud of my work, because I want to ensure that I want to work to ensure that people in my situation become the rule, not the exception, and that I see more people being able to live independently, to have jobs that pay sufficiently, and to be able to afford to be able to live the way I and several of my friends have. Because unfortunately, I know way too many people who are still in many cases dependent on family members for to pay the bills, or not able to get support to live the way they want to live. So it's a pleasure to be here, and I'm glad to be able to discuss this situation with you and with all of you. Thank you.
Thank you very much, James. Emmanuel, please share your thoughts with us.
Good morning, everyone. I'll try to make this as quick as possible. As we know, there are a lot of issues, but before I say that, I want to say thank you. This is my second time actually speaking after being sworn in, so I want to say thank you to the entire committee for recognizing my value and having me at the table. I'll start by saying this. I know some of us have mentioned the housing crisis. It is more than a crisis. About maybe 4 years ago, my family and I, my wife and my son, I've been married for 15 years. We were living in a home that was oversaw by a local agency that was a disability agency. And for the sake of the record, I will not say their name. But we were in this home. The home was fully accessible. The first year we lived there, everything was fine. They asked for a property increase, and because of that property increase, the rent went from $649 to $1,250. When it became $1,250, I saw the projection and I knew what was going to happen. As the rent raised, it became difficult for us to pay the rent. Even though I worked full time, it became difficult. That led to our eviction. So now we have a family that is homeless, and you have someone with a disability. You have a son that is required to get to school. You have to have a wife who has diabetes, homeless in the middle of winter. Long story short, I tried to work with the agency prior to the eviction, even before it became the rent became delinquent. Long story short, we ended up living in multiple hotels from Delaware to Maryland for about 8 months, trying to find an accessible home for a family is very, very difficult. On top of that, I went to work every day, didn't miss a beat. I even picked up a second job at the YMCA uh, to be able to cover the rent for the hotel. I will close by saying, not only is the housing a crisis, uh, we need accessible, affordable transportation. And I do not mean the medical appointments. I mean, if I wake up at 9 in the morning on a beautiful sunny day and want to go to Walmart to grab a tub of ice cream, I deserve that right to hop in a vehicle and go to the store. I may just want to go sit at the library or sit at the community center, whatever it may be. Um, the transportation is the barrier to everything, to employment, to healthcare, to living independently. I'll thank you for your time, and I look forward to working with this committee as we move the needle forward for people with disabilities to become fully included in American society.
Thank you very much, Emmanuel. Thank you. Jordan, are you ready to share your thoughts?
Hello, I'm Jordan Zimmerman, pronoun she and her. I communicate by typing on iPad, which then speaks my words aloud. I want to begin by thanking this committee for the time and tireless work in creating a report. It is a pleasure to work with you all, and I believe what we have created is an important statement on how we need the future to go. Today, I also want to share that as a person with a disability, the access myself and others in the community have continues to be hard to reach, and I believe the trajectory of this lack of services and supports and assumptions begin when we are young. When someone with an intellectual or developmental disability is in school, they have less than a 1/3 chance of being included for 80% of the day. This segregation in school leads a lack of access to education and technology, communication, and more, all of which we discussed yesterday. Even more so, it leads to segregation in the community, lifelong isolation, where we need our family to serve as unpaid caregivers to access support. This creates a vicious cycle, one that I've been stuck in before and know all too well, and that I know others have felt, where inferences are made about people with intellectual or developmental disabilities, leading to a disconnect between what people want and what professionals think, as well as the services available. It impacts employment and career possibilities for us, and the employment of those we need support from, when it is believed that disability is scary or less than, based on the mere fact of not being around us. Segregation in school is a direct barrier to engagement in life. So I have a question for all of us to consider. How can we expect to fix so many of the issues impacting our real lives, such as healthcare, employment, communication access, and caregiving, if the messaging being sent about people with intellectual and developmental disabilities, beginning in school, are so dismal?
Thank you very much, Jordan. Looking at my list, and it appears that Gabriel Martinez has not been able to join us this morning, so let me check my list one more time. I believe we have heard from all of our citizen members and have heard your thoughts on a barrier that needs to be addressed. So with that, and noting a change in our agenda, we're going to hear next again from Acting Commissioner Jennifer Johnson. We're moving up the topic of health equity. Thank you, Jennifer.
Okay, I think we're gonna be. Liz, I think spoke. Liz, yeah.
You spoke yesterday, right?
Yes. Okay. Yes, thank you. Okay, so yeah, we are switching up the agenda a little bit since we weren't able to get to Greg Link's presentation yesterday on the national strategy for family for caregiving. He's going to be coming back today, I believe at 11:20 or 11:40. So that's when he had time to come back to do that presentation. That was when I was supposed to present. So we're taking time right now for me to share the work that we're doing related to, yes.
Yes.
I think everyone spoke except for what's his name?
Next.
Max, he did not.
Max is not a citizen member.
Okay. So.
That's all right. Appreciate the backup. It takes
Yeah.
a village.
Yep.
That's good.
Yeah.
Thank you.
Okay, and I'm going to be speaking specifically about the work that we're doing related to health equity, which some of you have identified as an issue and barrier that people with IDD are facing in their daily living. I think we have a PowerPoint presentation to pull up. Okay, and what timing do we have? Okay, great. All right, so can you go to the next slide, please? To put the conversation in a bit of context as to why we talk about the importance of health equity as it relates to community living, it really is that, fundamentally, to be able to live well in the community, health is fundamental to that. And access to adequate health care is, again, fundamental to be able to live well in the community. And if we don't have that access, the ability to live well in the community is going to be compromised and really impacts the ability to go to work, to go to school, to go out and play and do things in the community. So that's why we talk about the importance of health equity as it relates to overall community living. Next slide, please. I think, again, a lot of you have talked about the various disparities that people experience as it relates to health, and that there are really multiple barriers to adequately accessing healthcare to support overall health and well-being. And there are, again, multiple barriers that exist and multiple disparities. And that's in screening and preventive services and getting access to that. Things like cancer diagnosis and treatment. We see that people with IDD do not have adequate access to that kind of diagnosis and treatment. Also, reproductive care and pregnancy care. Again, there are disparities in access to that kind of health care. Also, access to mental health care, which was talked about yesterday in the presentation about the Link Center. There's also issues around communication with healthcare providers in many different ways in terms of how a healthcare provider communicates with an individual with IDD, but also in the ways in which a person with IDD may be communicating with their healthcare provider. And then also overall looking at the satisfaction that people with IDD have less satisfaction with the overall quality of healthcare that they're getting. I think these are things that you all know well because you're probably living it, and, if not a daily basis, on a regular basis in your lives. And we also know that for people with what we call intersectional experiences, identities, those are going to be factors that make the disparities even worse. So if you are a person with IDD, comes from a minority population or has gender diversity, sexual orientation diversity, economic, you can put all those factors together, and it's going to be compounding the disparities that people with IDD experience. Next slide. So in identifying where the disparities exist and how people experience them, well, there are multiple reasons as to why we think there are these disparities that people with IDD experience. Some of it is related to the health conditions that people have and that they're very complex. And so it can be hard to provide adequate health care when there is so much complexity and perhaps multiple providers that have to be involved. There's also, and again, I think you all have described this well, disadvantages and what we call the social determinants of health. If you don't have access to transportation, if you don't have a job, if you are isolated, that makes it harder to get adequate health care or get to the healthcare provider. There may be preferences for care that you don't have available to you because of the limited availability of specialists, or not being able to, not having somebody in the local area who might be able to provide the kind of care that is needed. We've talked about the inadequate training of healthcare professionals and the importance of making sure that healthcare professionals get the training that they need to be able to provide healthcare to people with IDD. There's the issue of ableism, which again, I don't think I need to talk a whole lot about with this group in terms of the attitudes that healthcare providers bring to the healthcare experience or exchange and how that impacts healthcare. There's ineffective communication accommodations, as well as inaccessible medical diagnostic equipment, things like inaccessible weight scales and exam tables, which again are things that you all have talked about. In terms of, we heard yesterday about Section 504 and 1557 and the regulations that apply to healthcare. We also have the Americans with Disability Act requirements, and there being basically a lot of adequate knowledge of our healthcare professionals about those requirements. When we look at research and data, there's a whole lot of inadequate information within our research and data. Some of that may be because people with IDD are not included, they're excluded from clinical trials. And therefore, we don't know about the evidence of certain treatments for that population. And like I said, in terms of our data, we don't have adequate health surveillance data on the IDD population as we do with the rest of the population. And then related to the issue of ableism, there's medical discrimination, and that's a bit related to, related to the policy discussions that we had yesterday to address some of that medical discrimination that occurs. But specifically, some of that medical discrimination is around factors related to how decisions are made as it relates to quality of life and thoughts about quality of life and how that might impact access to care. So a lot of factors that are contributing to the health disparities. Next slide, please. One of the things that I like to share when I'm talking about this issue, just because I think it really speaks to and hones in on the medical experience that people with disabilities have. And this is research that has been led by Dr. Iazoni. And so some of you might be familiar with it, but she did a survey of physicians. And I think the survey results are just really quite sobering in terms of how it really reflects on the healthcare experience. So 80% of the physicians that were in this survey reported that they believe that people with significant disabilities have a worse quality of life than non-disabled people. So just think about, 80%. That is a significant portion. And this was of, about 700 physicians, but still very significant that 80% the people with disabilities have a lower quality of life. And so we go back to what we were talking about ableism and medical discrimination and how is that impacting the kind of healthcare people are getting. The next one that I think is really important is 40% were very confident about their ability to provide the same quality of care to patients with a disability as they do to patients without a disability. So not even half of our healthcare providers feel that they have the confidence to provide healthcare. Sean.
Just real fast, I know for me, like, I don't know who trained my medical provider, but she is in the top 40%. She's awesome. But I will say my all the comments for the end. Thank you.
Okay, thank you. And I'm glad that you have a healthcare provider that you can trust and is providing good healthcare. The last one statistic is that just about 57% strongly agreed that they welcomed patients with disabilities into their practices. And while, you know, at least that's more than half, it's still not the same in terms of welcoming people without disabilities into their practice, and still is not clearly at a level that it should be in terms of welcoming people with disabilities. So again, just taking these three statistics alone, which there's part of a larger information about how physicians' perceptions of their care for people with disabilities. Yeah, that, you know, how does this really impact healthcare disparities for people with disabilities? James.
I don't know, it's a good time to ask this question. You could tell me I should wait to ask this question. I remember several years, it's almost a decade ago, but I have a sibling with disabilities, and his name is Joe. And Joe, who's, how I could say, he fall in between the IDD committee and not. And he had like a big, massive stroke. And he's very lucky that California don't have a waiting list for him. He got the services needed, but at the same time, it took some time because he had to go physical therapy, get his strength back. But at the same time, he have another stroke. But I feel like we need to somehow help those who fall in between the cracks, whose health is good, and others, because he's could fall into the D system, but sometimes he cannot fall into the PD system.
Yeah.
And I'm worried about those folks. And also I'm worried about people like myself and Tia and the others in the room. We're not like spring chickens no more. We're getting older and older. And I cannot see myself after the age of 65 because I have a couple of people who help me and support me, but they're also aging.
Yeah.
And we need to somehow have safeguards for us too, because we may have a stroke or may need assistance after age 65.
Yep. So I think you teed me up very well for the next slide, which, oh no, you don't have to apologize. You led us very well, quite well into what we are doing to address some of these issues. And yeah, there is definitely the fact that people with IDD are living longer lives, which is really great and something to celebrate. But then we also have to be thinking about how are we not only is that happening, but how do we continue to increase that life expectancy for people with IDD? But also how do we prepare and the system for the increased life expectancy? And really looking at how do we then promote health equity to be able to do that, and health equity across the lifespan. Next slide, please. So we have. I'm sorry. Okay. All right. I just wanted to make sure. Lucy, did you have something you wanted to share?
Yeah, I just wanted to make sure that Santa and and what's her name?
Kara.
Carol got a chance to speak.
They did. They spoke yesterday.
Okay.
We had time for them to be able to speak yesterday.
Okay,
Even though
great.
their names were on, I think, the list for today.
Okay,
Yeah.
I missed that, so I just want to make sure that
Yeah.
they got a chance.
Yeah, thanks for checking on that.
Of course.
Okay, so with all of that, for the Administration on Disabilities, we really have set a vision for health equity. It is one of our priorities within the Administration on Disabilities. And with our vision, what we really hope for and seek to achieve is that people with disabilities are living well with their disabilities, and that they have healthcare experiences that lead to better health outcomes and reduced health disparities that increases life expectancy. And they have equitable access to healthcare that supports them in achieving their maximum physical, emotional, social, and economic well-being that is also consistent with their cultural values. That they are receiving person-centered and self-directed care where their decisions are supported, so treated with respect and dignity. And that they have providers who understand them, that are culturally competent and value, and again, respect their personal preferences and communication methods. So that's our overall vision of a perfect health world and healthcare experience for people with disabilities. So that's lofty. If you go to the next slide, we have broken down this vision into goals. And we have a number of goals, the first set of which are really around the system and what are our goals for the system. And that what we are aiming for is that we have a broader health environment and system that has plans for accessible services for individuals with disabilities. And that, again, medical professionals have greater cultural competency and are better able to serve people with disabilities. And again, are treating people with respect and dignity and presuming competence in the decision-making about their health. We want healthcare that is influenced by and responsive to social factors. So getting at those social determinants of health, and that people with disabilities are asked about those things during their healthcare appointment. And that we do have research and data that is inclusive of people with IDD, so that we can use that information to inform our programs, our policy, and healthcare practice. Next slide is our continued goal for health equity, which is really focused on the individual, and that individuals, including those that have intersectional identities, are seen as experts in their own healthcare and also in their disability, that they are receiving person-centered healthcare, that they have increased access to healthcare procedures, and they have opportunities to provide input, again, ask questions about things like, do you have a job? Do you have transportation? Do you have friends? Do you go out in the community? Ask those kinds of things during their healthcare visit. And also, again, that they have data on them related to their health and research on their health to inform practice. So we are investing, I'm sorry, the next slide. We have a number of projects that we are investing in to try and chip away. Our investments are not going to make all the difference in a very huge health system, but what we're trying to do is make a difference in terms of showing where it can happen, how it can work, and how we can make healthcare more accessible to achieve greater health equity for people with disabilities. So one of the projects we have is the Center for Transition to Adult Healthcare for Youth with Disabilities. And this is a project that is working on resources and tools for youth with disabilities to be able to transition into adult healthcare, and also address and give resources to the healthcare field to be able to support that transition. So that's one of our projects. The next one is partnering to transform health outcomes with persons with IDD, or path PWIDD. And this is the project that we've been funding that is working with medical education training programs to integrate content on IDD into those training programs. So future medical professionals are getting that training before they go out into the field. The next project you have, which you can't see on the slide in the room because of the captioning, is the National Center for Disability Equity and Intersectionality. So this is a bit of a higher level or national level work that we're doing to really get at issues of ableism and medical discrimination, and developing tools for healthcare providers and others to use to really evaluate their practice to determine whether it is competent and what kind of changes they need to make it more culturally competent or disability competent. Next slide. The other project that we are funding is the Link Center, which you heard about yesterday, so I don't think I need to describe that. We also have another smaller project related to the issue of co-occurring IDD and mental health disabilities, and these are 5 grants to states. It has a very long name, since the State Intersystem Services Training and Planning. But just basically, again, there are grants to 5 states that are bringing multidisciplinary teams together to break down those silos between the DD and mental health systems. And then the last project, last project is what we call IDD Counts. And this is the project that we're working on to really get at those data issues and making sure that we have data systems and we're collecting data that is inclusive of people with IDD, so we know about their health in comparison to the rest of the population.
Thank you very much, Jennifer. So yes, Santa, please lead us off. We really have time now for conversation, whatever, your thoughts and questions. We'll start with Santa, we'll come to Liz, we'll go to James. We'll start with those 3 and then we'll get to you. Santa, please.
I am really happy that you are talking about this, about time. I think about when I was young, long time ago. Nobody ever told me about when I get older, my body will change a lot. And I remember in high school, talk about when about your body, but maybe no, that never about when I got older. I feel that you have to talk about that. And also, we have to talk about people with people with dementia, and how it's how that going to look like, because What? It's whole different road trip. Road is a lot of different road trip for people with dementia.
Thank you.
Okay.
Thank you, Santa. Thank you very much. So I'd like to hear from Liz, then James, then Sean. Liz?
First of all, it's so nice to be in the room. To talk about two things that I think are kind of related. Believing in people with, I think that lots of time the medical field don't believe in people with disability, don't try to help people understand what's going on. I do have a wonderful physician that spends probably less than 5 minutes just chit chatting. How was my vacation? How was my day? How those kinds of things, because that's so that might not have anything to do with your health. You might be saying, well, why does the doctor need to understand my vacation to understand that what's wrong with me? But that's, if you don't understand the person, if you don't understand where the person is coming from, how can you understand their health and what's happening with their health? And the other thing, well, two more things. One is plain language. Sometimes I don't understand what the doctor is saying to me, and I don't go with anyone, my DSP or my family member. I choose not to, and that's my right. But when just a quick story, when I was diagnosed with
Liz,
diabetes.
I'm going to ask you to try to give us your second and third point so that we could hear from James and Sean. Would you mind?
Sure.
Thank you, dear.
When I was and they're kind of related. When I was diagnosed with diabetes, I didn't understand all the rules of what to eat, and I brought my husband, and he also has a disability, and both of us didn't know what's going on. And I just think, just wrapping up, I think that it's really important to believe in people with disability. Thank you.
Thank you very much. Thank you, Liz. James and then Sean. I'm also being prompted that someone in our Zoom room would like to speak. So Sean, first James and then Sean.
I have a couple of things be helpful. I remember several years ago, I did a interesting survey with my medical doctor, and the nurse was that I was working on a grant about how we educate physicians and doctors and nurses about how to deal with sexual assault. And when I was testing them what they need to do if someone got sexual assaulted, they did not answer that question. Did not know what to do when a person disclosed about sexual assault. I feel like we need to have something in there about people who've been sexually assaulted, because sometimes they go to the doctor to tell what happened. Oh, wait. to what happened because no one teach the doctors or nurses about when someone disclosed about them being assaulted by another person. And it feels like we need to have something about sexual assault, part of the training, and also in this document, because we talk about healthy relationships. And I think it's important to have something about sexual assault because that's being safe and being healthy, because you could
Absolutely.
get AIDS or herpes or.
Thank you, James. So I'm going to try to get as many people's voices heard during this next 7 minutes. So Sean, then we're going to go to Emmanuel, who's in our Zoom room, and then we're going to come to Jordan.
I just want to say for first off, Emmanuel, my friend, my brother, welcome to the board. Like I saw you since I think June, but you is a great addition to this team. Happy to have you fighting the good fight. Ju- just real fast. I think in order for us to have major change, like we have to have some type of training and a board or certification that doctors and medical professionals should go through to make sure that also to make sure that they have completed and doing the services
Yeah,
that they say that they should do.
thank you.
Thank you.
Great. Chairman, did you have a question now?
If I could just, in my previous hat, serving on the National Council on Disability, we worked on oral health and dental care because what we heard from so many parents that we cannot find a dentist who will take care of their son or daughter. And what we came up with is that we did a survey with dentists, and most of the dentists said, I don't know how to diagnose and I don't know how to treat. So what we did for 5 years, we said, we got to work with the dental schools before they graduate a dentist, that there is one course on how to diagnose and treat. And finally, we got every dental school in the country to have one course, so they don't say anymore, oh, we don't know how to diagnose or treat because we were never trained. I think what we need to do is work with the medical schools to say, I think you got to update your curriculum on how you treat people with disabilities. And that's the only way I think we can
Thank you.
address it.
Thank you. So, sorry, Sean, Emmanuel, and then Jordan, you're going to have the last word. Emmanuel, let's hear what you're thinking.
Thank you so much, and thank you, Sean, for your words. What I'm really thinking about is 2 quick points. One, I think when we talk about the medical setting, medical providers, doctors, nurses, etc., a lot of times, and as advocates, we are willing. Some of us are willing to share our experiences and resources and knowledge. But I find it real troubling to get a call from a doctor who's making, let's say, $100,000 a year for my resources and my knowledge and wanting me to talk to their patients, wanting me to give them not only the patients, but give the doctors resources, but they don't want to pay us for our knowledge and experiences. That's point one. Point two, when we talk about the healthcare system, people with disabilities those with diabetes, et cetera, don't have access to the information about food and what to eat, what not to eat, how to manage diabetes. For one, it is because um, sometimes we are seen as not worth living. So why give us the information? I don't believe in a healthcare system. It is a sick care system because that is the only time we access those those reps. I just wanted to share that I think it goes beyond. Yes, we are willing to train. Yes, we need to be part of the training, but we also need to be compensated for our knowledge and experiences when we come to the table.
Thank you, Emmanuel. Jordan, please.
I'm really grateful for this health equity work. Something I think about often is how there are not many AAC users, older than me, living in the community, accessing support. Where does everyone go? What happens to our community? What can we and others believe about our future? I hope this project looks at that too.
Thank you. We see a lot of additional hands. Lucy would like to say something, and then Kathy, and then we must move on to the next topic. And Kara.
Two quick,
Okay, please be brief.
two very quick things. First of all, I couldn't agree with Liz more. It was a great speech. And number two, I couldn't agree with the doctor opinion more. Because sometimes, more often than not, the doctors pay attention to the parents that are taking the kids to the appointments when they should be listening to the patients who are there to say what they believe needs to be done.
Thank you, Lucy. Kathy?
I just wanted to point out I know for us, the disconnect is often with the insurance company, we have fantastic providers, like so many have already said. We have a neurologist and a primary care doc that know what they're doing. They've known our guys forever. They have prescribed things. They have prescribed procedures that every single one keeps getting challenged. And my husband and I have the wherewithal to do those fights, to call to 4 and 5 times, take those denial letters and do something with them to turn it around. But we know too that that's not the case for everybody. And we also can pay out of pocket if we need to. And that's certainly not the case for everybody. So I just think that we need to note that it's
Thank you for adding
oftentimes
that.
the insurance.
Thank you for adding that. Okay, Kara, really the last word.
I know what, but what we want the doctors is that we do want doctors to tell. I do work with the doctors who work with the people who want to become doctors. Well,
I didn't understand this.
I do want the doctor do it.
Oh, she was going to tell you about a wonderful physician we have in the District of Columbia. He's training medical students and uses our advocacy organization to train docs and students. To do, and that's all. We do a lot of doctor shopping.
Well, that's great, and we're happy to, to have a balance in hearing, both where the challenges are as well as, the positive things that are starting to happen, person by person in the community. So thank you, Kara. Thank you, everybody. Your insights are so important, and it's very hard to, keep to our time. But we have other topics that are going to be just as interesting that we want your insights are on. So we're going to make that change now, and we're moving into a new topic, and we're going to begin to talk about addressing the barriers. We're going to hear from our federal agencies, from our PCPID ex officio member agencies. I'm going to let each person introduce themselves, and we're going to begin with Taryn Williams. Taryn is joining us through our Zoom room. Good morning, Taryn.
Good morning, and thank you for having me. Is everyone able to hear me?
Yes, very well.
Great, thank you. I appreciate having the opportunity to speak today about some of our work at the U.S. Department of Labor. By way of introduction, I'm Taryn Williams, and I serve as Assistant Secretary of Labor for Disability Employment Policy. And in that role, I lead our Office of Disability Employment Policy, which we sometimes call ODEP or ODEP. I want to thank all of our partners on PCPID for your crucial work in advising President Biden and Secretary Becerra on issues facing people with intellectual disabilities and their families. I also want to give a little bit of background about our agency. ODEP is a non-regulatory federal agency that, rather than putting out official rules, works to promote policies and coordinates with employers and all levels of government to increase workplace success for people with disabilities. It is our mission to develop and influence both policies and practices that increase the number and the quality of employment opportunities for people with disabilities. As a small agency, we can't do our work without partnering with other federal agencies, such as those that are with us today. This coordination is really important because the issues that we work on for people with disabilities are all closely linked. We know that employment plays an important role in health. It also plays an important role in community living. Recently, ODEP developed a competitive integrated employment transformation hub. It provides a wide variety of resources from ODEP and other federal partners, including other agencies within the Department of Labor, the Department of Education, Health and Human Services, and the Social Security Administration. The hub, as we call it, is split up in sections meant to help different groups of stakeholders that we work with. First, and most importantly, people with disabilities and their families. It's also has resources for employment service providers, for state government agencies, and also employers. Each section of the hub contains resources on a number of topics. That includes accommodations, financial resources, information about benefits and how to manage your benefits, youth transition from high school into college and employment, and how to create workplaces that support and welcome people with disabilities. We also offer success stories in employment, those that really demonstrate that competitive integrated employment is possible. for everyone. So I would love for all of you to check out our transformation hub, as we call it, and I will make sure that you have the link. We are also doing work to strengthen the direct support professionals workforce. We know, like you, that direct support professionals provide really important services to ensure that people with disabilities can live in their communities. We also know that people with disabilities and their families rely on these services every day. But as the PCPID report makes clear, we're in a workforce shortage crisis. We know that there is a vacancy rate for direct support professionals among provider organizations. We also know that there are really high turnover rates. And we expect that the demand for direct support professionals is going to increase dramatically over the next 40 years. That is why ODEP is working to build capacity and to strengthen the direct support professional workforce. A few years ago in 2022, one of our centers that works to support people with disabilities convened a meeting with experts to identify challenges faced by this workforce and to make recommendations for possible actions that we can take as agencies to address the crisis. As part of our follow-up to that meeting, we released a report on how we can bring more direct support professionals into the job. It calls for really honoring the work that direct support professionals do every day and making it clear that their work is critical to our national interests. Later on in this year, we will also be doing another report that focuses on apprenticeship programs. So creating pathways for individuals to enter the profession while also earning wages. We know that building up the direct support professional workforce is really important to so many people with disabilities, including those with intellectual and developmental disabilities and their families. We also know that DSPs, as we sometimes call it, provide reliable and quality services and supports to people with disabilities so they can live, work, and be a part of their communities. And we understand that the families also rely on this important workforce as well. Together, I believe we can address these challenges and improve access to direct support professionals for Americans with disabilities who rely on their support each day. And I just want to say in closing, thank you again for the opportunity to talk about some of the work that we're doing at the Office of Disability Employment Policy. It is an important part of our mission to improve the lives of people with intellectual and developmental disabilities. And we also want to share a big thank you to the Administration for Community Living and our partners on PCPID for your ongoing collaboration and support. And I'm looking forward to joining you for this entire session. My apologies that I can't be there in person, and I also look forward to responding to any questions you have. Thank you.
Thank you very much, Taryn. We're going to have time for just 2 questions. Again, we have more time for questions today, but not going to be enough time. So the first hand that I saw was Tia's, and then Jordan.
Okay, great.
Tia?
So my question to you is, are you working with vocational rehabilitation? Because it's a shame to hear that all the voc rehabs are giving back millions, billions of dollars that they could be using to help people with disabilities get jobs. And some of them aren't working right. They don't have the right training. When I was growing up, my voc rehab counselor told me I can either work at a sheltered workshop, collect SSDI, and stay home all day. That was my choices. I think that is so wrong. I think we need to work with them and help get them trained on what people need jobs and what kind of jobs that they can do. And also help them not have to give billions of dollars back to the government when we need that money to help people get employment.
Thank you, Tia. Sharon?
Thank you for that question, Tia. Yes, we do work with vocational rehabilitation, and we do so in a few ways that I would mention now. First, you mentioned the millions of dollars that the agencies are returning each year. And those millions of dollars have been recompeted to the agencies as part of the Disability Innovation Fund. We have collaborated with our partners over at RSA, and we share a goal of ensuring that those dollars that go out as part of those Disability Innovation Fund grants are advancing competitive integrated employment. So that's one example of the work that we're doing to ensure that those dollars get spent by states to advance employment in the community. Another way that we partner with vocational rehabilitation is in our youth work. ODUP has a team that focuses solely on youth and young adults with disabilities and making sure that they are successful in getting jobs as they move into adulthood. RSA, Vocational Rehabilitation, is one of their key partners. Every quarter, we have formal meetings just to focus on the needs of youth and young adults with disabilities, and those include vocational rehabilitation and members from that agency. But even beyond the quarterly meetings, it's probably not a few weeks go by that we are not working with our partners over at the agency. There are other ways that we coordinate, but I want to make sure I get to the other question. But the answer to your question is yes, we do coordinate.
Thank you, Taryn. Please, Jordan.
I'm curious if there's any discussion of having the role of a DSP be an actual prerequisite to other professions, such as speech pathologists, physical therapists, educators, doctors, and more. If being a DSP was an actual part of a practicum or something that could have a positive impact on all.
Yes, that is a great question. Thank you for that question as well. Yes, we have talked about the ways that a DSP role can be part of a broader career. Sometimes we call it a career ladder or career progression. We know, like you, that the skills and the knowledge that a DSP gains while they're doing their jobs directly relate to the skills and knowledge of many other roles. And we think one of the ways that we can address the workforce crisis is by ensuring that DSPs know that the work that they're doing and their role can lead to jobs or careers in other areas, and also ensuring that when training and education is happening for those other roles, that they become aware that DSP is one possible job as they go on to start their career. So yes, that's a part of how we think about strategies for addressing the crisis. And I can make sure that you have the report that we've already published on this issue and the reports that we will continue to publish because this is such a priority for us.
Thank you, Taryn. Members, I'm going to apologize, but we're going to have to move to our next topic. We have 4 more speakers to hear from in this section. I'll come to you, James, first after our next presenter, and that is Kelly Buckland. Kelly, good morning.
Can you hear me? You all hear me okay? All right, so do you have my slides?
So, yes, here we go. Next slide. There we go.
All right, so I was appointed to this position. Well, first let me introduce myself. I'm Kelly Buckland. I'm the Disability Policy Advisor to Secretary Buttigieg at the U.S. Department of Transportation. And I was appointed to that position by President Biden in September of 21, so just coming up on my anniversary. I am a white old male who wears a cowboy hat because I actually was a cowboy. Raised on a potato farm and cattle ranch in Idaho. So I actually did like do branding and all that stuff. Anyway, and I would just let you all know, I've been having a great time at this job. We've been making a lot of different changes to transportation for the better. And I'm going to walk you through that. But when I first got there, what we did was developed a set of disability policy priorities. And the secretary approved those in July of 22, actually on the ADA anniversary event. And so there's 4 pillars that we developed. One was safe and accessible air travel, because it's neither for people with disabilities right now. I'm sure most of you already know that. But people have been not just inconvenienced, but their chairs have been destroyed. Other types of equipment have been destroyed. They have had their bodies damaged from being lifted wrong and dropped. And some people have even died as a result of injuries they received on the airplane. So we've made a number of changes, and I know you guys wanted me to change the length, so I'm gonna like change the format a lot. So I'm probably not gonna follow every one of these slides, so I'll just tell you when to go through it. Under enabling safe and accessible air travel, we had several goals under that. One was to put accessible bathrooms on single aisle aircraft. They're already required on wide body jets, but they were not required on single aisle aircraft. We completed that rule in July of 23. So restrooms on airplanes are now required to be accessible on single aisle aircraft. There's an implementation period. Sorry, I keep hitting this microphone. There's an implementation period. So some things are happening now. Actually, like they have to get a onboard wheelchair, and that's not what it sounds like. It's a chair to get you from your seat to the toilet, and it's not really a wheelchair. It's just sort of like a stool with wheels on it. But anyway, and then the other thing that we were going to do was develop a rule that would guarantee the safety and dignity of people with disabilities when they fly. So that rule went out in February, and we got 2,000 comments back. So we've been sorting through the comments and changing the rule as necessary. We've also been looking at it in regards to the Chevron decision, which is a decision of the Supreme Court that limits what you can do through rulemaking. And you may have to go back to get law passed, actually. So we've been keeping an eye on that so that we don't get sued and get tangled up in court for years. And the other thing that we have been doing is holding it up against the reauthorization of the Air Carrier Access Act. So that was reauthorized this year, and there's a number of things they directed the Department of Transportation to do, which includes most of the stuff we're already doing. So Senator Duckworth, what she wanted to do was to codify this stuff in law, because the new administration could come in and change the rules. But if it's in statute, then they can't do that. So she's really sort of like guaranteeing the work that we do will be there for future generations. So the other thing we are working on is research to put a wheelchair spot on airplanes. So you know, like if you get on a bus, you get on a train, you get on a boat, you get on any other form of transportation, you stay in your wheelchair. We're going to make that happen on airplanes so that people's chairs aren't taken from them, and so that they don't get hurt from being lifted and dropped and that sort of stuff. So we have made incredible progress on this. The FAA has been doing research over the last 2 years. They got one more year before they will complete it. But we're projecting that we will have wheelchair accessible seating on airplanes in 1 to 3 more years, which is amazing because people weren't even talking about this when I was appointed. So anyway, so then I'm gonna move to enabling multimodal accessibility. If you could stay with the slide I was on. Well, this works. So no, I'll go back to the slide I was. So we've been, as you may know, the Access Board developed PROAG, which is the Public Rights of Way Accessibility Guidelines. That's what PROAG stands for. So Access Board passed theirs, so that now there's a minimum level for PROAG. So what it does is it addresses sidewalks, curb cuts, that sort of stuff. So DOT started adopting our part of that, because it doesn't become enforceable until DOT and the Department of Justice adopt PROAG, their own versions of it, because we can make it stricter. We can't make it less strict, but we can make it stricter. So what we decided to do at DOT was to just adopt what the Access Board had done so that it would be adopted by us and then would be enforceable. DOJ is not going to get to it this year or next, probably. Their bandwidth is pretty narrow. So at least that's what we're told. So we're going to probably publish the final rule on that next month. Well, November. I know we're still in September, but we're almost done. Anyway, so and then under that same category, we really also focused on Amtrak. We have developed completely accessible new rail cars for Amtrak. Those are some of them have already been completed and built, but most of them are still in the construction stage. But those new trains should hit the tracks sometime later this year or next year. And when you see those trains, you're going to be amazed, because the rail cars are going to be really accessible, and you're going to be able, if you use a wheelchair, you're going to be able to go from one end of the train to the other end of the train. You'll be able to go to the dining car. You won't have to send people for food. They're going to have lifts on each side of the car. All the communication systems are going to be accessible to people who are either blind or deaf or need some assistance with communications.
Kelly, excuse my interruption, but this is your 1 minute notice.
Okay, I'll try to. So we're now in the process of designing the over the road trains, or over the country trains, the long haul trains. And as you know, most of those are double decker. We're going to keep them double decker, and we're going to put elevators in them. So you'll still, again, be able to go from one end of the train to the other. You'll be able to go to the observation car, to the dining car, all that stuff that you currently can't do. I'm going to go through the last two real quick, and then there's some overarching issues as well. But we also wanted to enable access to good paying jobs for people with disabilities. And I'll bring this up on purpose because I'm following Taryn. There are a lot of jobs in transit. And there's a lot more jobs in transit and construction right now than there has ever been because of the bipartisan infrastructure law. So there's a whole bunch of jobs out there. We've created millions and millions of jobs. People with disabilities should get their share of those jobs. And yet, I think because of stereotype and misinformation, people with disabilities, including people with intellectual disabilities and developmental disabilities, and construction companies and transit don't think about people with disabilities in those jobs, but I'm asking you to do that. Start thinking of yourselves in those jobs. There's a bunch of them out there. So if you're not already employed, start thinking about a job in transit or in construction. And then the last one is enabling accessibility of electric vehicles and also automated vehicles. Right now, if you're a person with disability that uses a wheelchair, you cannot purchase either one of them. So they just don't exist. So all the stuff around electric cars, there's not one for people with disabilities. And all the stuff around automated vehicles, like May Mobility is operating in California and several, there's no driver, no accessible vehicles. There has to be a driver in order for you to be secured into the car. So if there's no driver, you don't get secured, which means you can't ride on it. So we're working on all of that stuff. We did work with the Access Board to make sure that the rule around electric fueling stations are accessible to people with disabilities.
Excuse my interruption, Kelly. We really have to allow
I'll just
time
finish this- I'll just
for
finish this
people
one.
to ask their questions.
I'll just finish this one last thought. And
Thank
that is the accessible fueling systems. We did work with the Access Board. They're working on a final rule on that, but right now the guidelines are out and it's in our rules and regs. So anybody standing up a fueling station, electric fueling station, it has to be accessible. So with that.
Thank you. And I'm
apologize.
going to just keep apologizing and keep moving us forward. So I saw Sean's hand up. Oh, I promised you first, James. So James, you get the first moment here, and then Emmanuel's hand was up. So we have to give equal time to people who are not in the room. James?
I have a question about the transportation piece. I know for us, for traveling from point A to point B, it's a challenge because sometimes we have to go TSA. And the challenging thing sometimes when I go through TSA, sometimes they don't take it serious what I'm saying and what I need and want. As a sexual assault survivor, when I tell them I'm a sexual assault survivor, they roll their eyes. And they don't tell me where they're going to touch me because they don't ask and say, you need to tell me where you're going to touch me next or feel me. And when I try to do the TSA cares, it's more a challenge now than early on because you used to talk to a person, but now it's everything's automatic and it's more harder to get your needs and wants to understand, get the support you need when you go through the TSA. Because I remember several years ago, myself and other self-advocates met with the TSA people. They listened to us, but they took
Let's
it
hear
serious.
what Kelly has to say and any reply.
So TSA is under the Department of Homeland Security. We're not part of that. So I can't change what they do. Believe me, every time I get on an airplane, James, they put their hands inside my pants because that's how they pat you down. And it is, it's disgusting what they do. And the problem
I have
is,
a suggestion.
the problem is it doesn't even secure the airplane. If it secured the airplane, actually, I think it would be different, but it doesn't.
So we're going
So-
to have that noted.
Do you
hear-
ever use TSA Cares? Let me just.
Yeah.
Because TSA Cares, I've never used it, but some people use it and have good success with it. So
I have a suggestion for the next meeting. We should have someone from TSA Cares in the disability side of things to have public input.
Or as Jennifer said, maybe that should be one of your.
It could be one of the
next
focus
report
areas.
issues.
Thank you. Okay, so James, duly noted, and we're going to get to that at the very end of the day where you're going to have an opportunity to consider focus areas. Emmanuel, what did you want to add to, or ask about?
I just wanted to say, due to time restrictions, well, number one, are you reachable by email? Two, I'm not sure if it's your department, but I know for people who need to travel with a personal care attendant on an airplane, I recently had to book 2 tickets to travel with this personal care attendant, and then my so that happened and I wasn't able to go, and I'm not asking for a refund for my ticket, but because my personal care attendant's name is on that ticket, she is now the one that needs to travel with me. However, that person may not be working for me when I go to reschedule that trip. So I wondered if there's a policy that can be designed where refund or transfer of a ticket would qualify for another personal care attendant to switch that ticket to.
Kelly?
So
Any-
you should be able to switch it already.
So can you share an email address perhaps?
Absolutely. And what I was gonna ask, if you could send my slides out to everybody.
They have them.
Okay, cool. Yeah, it's kelly.buckland@dot.gov.
We'll
Thank
get
you so
that to you,
much.
Emmanuel, for
So it's pretty
additional
easy. So
assistance.
one more thing I'll add on the attendance stuff. We are looking at the attendance flying either half price or free. That already occurs in some countries, like in Europe. The attendant flies for free. So we've started looking at that, but we don't have enough time left in this term to address it.
Thank you. Okay.
Thank you so much.
Thank you, Emmanuel. Members, we'd like your input. We're considering reducing lunch time, taking 20 minutes back from lunch, giving you 45 minutes for lunch, and allowing for more time in this section of the day. Can I see a show of hands? All agreed? If you agree? Anyone disagree? If anyone anyone online, put that something into the chat so we know thank you, Joe. Appreciate that. Thumbs up. Emmanuel, are you okay with that? We're going to go with the majority. Thank you.
Yes,
I'm going to
ma'am.
adjust the agenda as we continue talking. Next, we're going to hear from, thank you, Kelly. Next, we're going to hear from Todd Wilson. Todd?
Hi, everyone. I'm Todd Wilson. I'm the team lead for the Money Follows the Person demonstration in the Division of Community Systems Transformation at CMS. You may have heard MFP, Money Follows the Person. Today, I would like to share some CMS resources to support individuals with intellectual and developmental disabilities and their aging caregivers.
The mic closer to you.
Sure. The number of people with IDD and their aging caregivers is increasing, as we heard earlier. According to a 2018 study through the University of Minnesota, the Residential Information Systems Project, there were an estimated 7.43 million people with IDD in the US. Only 21% or 1.54 million people with IDD were known to or received services through state IDD agencies, with an overwhelming majority of these individuals receiving Medicaid-funded long-term services and supports. An estimated 1 million households in the US include an adult with IDD living with and supported by an aging caregiver, and this number is growing. The number of people with IDD receiving Medicaid home and community-based services and living with a family increased by 143% between 1998 and 2018. These increases lead to a higher demand for state and federally funded services, primarily through Medicaid and home and community-based waiver programs. Next slide. Most family members supporting an adult with IDD are parents. Family caregivers provide support and assistance for various needs such as budgeting and finance, transportation, shopping, and essential activities of daily living. As parents and caregivers age, they may become less able to provide support for the person with IDD because of their own illness or other health concerns. New supports may be necessary for both the person with IDD and their aging family member to remain in the home. Person-centered planning for the future care needs of adults with IDD is crucial to ensuring that the person can live and receive necessary support in the setting of their choice. Next slide. Last year, CMS released a set of resources designed to support state Medicaid and partner agencies that play critical roles in developing and delivering supports and services that meet the current and future needs of adults with intellectual and developmental disabilities and their aging parents and caregivers. These resource briefs were developed through a culmination of a 3-year contract between CMS and the Lewin Group that included a 2-day summit, a 6-month learning collaborative with state agencies, and coordination of technical expert work group. Next slide. The first brief synthesizes information on innovative state strategies and programs designed to strengthen supports for adults with IDD and their aging caregivers who often provide substantial supports in addition to those provided through HCBS programs. The document highlights specific state initiatives which provide practical insights into effective strategies for supporting adults with IDD and their aging caregivers. Strategies included in this resource include 4 key focus areas: building interagency partnerships and relationships, engagement and navigation supports, person and family-centered systems of support, and planning for the future. States can enhance support for adults with IDD and their aging caregivers by fostering strong partnerships between the state Medicaid agency and other key state agencies, such as IDD, aging, and mental health. This coordination ensures streamlined person and family-centered services. States should engage individuals with IDD and their families in the design, implementation, and evaluation of those programs and services. Leveraging no wrong door systems can help create coordinated system of access to LTSS, making it easier for individuals and families to navigate and access services. Embedding person and family-centered practices into various processes such as assessments, planning, service authorization, and budgeting is crucial. Early engagement with families and caregivers can help states better understand and meet current needs and future needs. States should support individuals and families in planning for future transitions and changes, such as retirement changes and changes in eligibility for Medicare or Social Security disability insurance. Designing flexible service options and incorporating supported decision-making can help align services with individual preferences and needs over time. Next slide. The second brief provides information to state agencies on how to anticipate and meet the needs of adults with IDD and their aging caregivers. Strategies for states to consider include data collection and analysis, holistic planning and collaboration, no wrong door systems, as I mentioned before, and stakeholder engagement. Many states prioritize services for individuals with IDD who have aging caregivers. This includes using waiver programs, reserved capacity, and targeted supports to ensure these individuals receive necessary care as their caregivers age. High quality data is crucial for state agencies to drive system performance, to forecast future service needs, to identify those data gaps, and address social and health disparities. Accurate data helps an early intervention to avert crises and improve health and welfare strategies. State Medicaid agencies may adopt holistic approaches to collaborate with their sister agencies for aging, mental health, IDD, to effectively support individuals and their caregivers. This includes sharing data across agencies to inform planning and improve service delivery. Strengthening the no wrong door systems can improve access to long-term services and supports as they coordinated access and support transitions between care settings. Continuous and meaningful engagement with individuals with IDD, their caregivers, and community-based organizations is essential. This helps gather valuable insights, inform policy, and to ensure services meet the needs and preferences of individuals and their families. Next slide. The next brief focuses on the importance of person-centered planning. CMS requires Medicaid HCBS programs to use a person-centered planning process that reflects individual preferences and goals directed by the individual with the option to include chosen representatives. Applying person-centered principles across the lifespan becomes increasingly important as the number of people with IDD living with aging caregivers grows. These principles can help align people's choices, family context, and community resources in ways that foster state agency innovation. As caregivers age, they may need additional support or may be less able to provide care, making early and ongoing planning essential to address the evolving needs of individuals with IDD and their caregivers. Effective person-centered planning must consider cultural and linguistic factors, recognizing the diversity of families and the importance of cultural competence in supporting those individuals. Various states have implemented specific programs and resources to support person-centered planning, including online tools, webinars, peer monitoring, peer mentoring, and community feedback mechanisms. Next slide. The final brief offers state strategies to enhance supports for aging caregivers and adults with IDD. States increasingly recognize the need to conduct strategic and ongoing planning to expand and strengthen HCBS for adults with IDD and consider the HCBS needs of adults with IDD and their aging caregivers. Planning takes the collective efforts of state Medicaid agencies, state IDD agencies, state aging agencies, and other partners, along with ongoing involvement of people with IDD and their aging caregivers. States are encouraged to engage with diverse communities through listening forums and feedback loops to ensure that services are equitable and responsive to the evolving needs of individuals. Assistance may include technology, mental health interventions, training, self-care, and rest, and financial resources. Aging caregivers may benefit from support in navigating their own changing needs, as well as strategies to assist them in supporting family members. States have the flexibility to design HCBS waiver programs with options to best meet the needs of individuals with IDD in the context of their families. For example, some states reserve capacity in the waiver programs for individuals with an aging caregiver, which allows individuals to enter, leave, and return the waiver program as their needs dictate.
And Todd, I have to interrupt you and give you a 1-minute notice,
All right,
please.
and I'm just wrapping up. Thank you.
Wonderful.
States have the option to tailor services to meet the needs of a particular target group or groups using different HCBS authorities. Often the systems that support older adults and individuals with IDD have different services, different providers, and case management approaches. The use of such HCBS authorities could help states to enable a seamlessly coordinated system of supports for both adults with IDD and their aging caregivers, which deploys services and resources based on the totality of the circumstances. States can choose to provide additional services under Medicaid HCBS waiver programs and state plan authority that support caregivers in meeting the needs of Medicaid participants, such as respite, home health, and case management. And the last slide. And this is just references for statistical information.
Very good. Thank you so much. Okay, we have time again for 2 questions or comments. James, I do see your hand, but I want to make sure that anybody who hasn't spoken recently may want to join the conversation. But I don't see anyone at this time. So James, let's hear what you're thinking.
I have concerns about it. We have about 240,000 people waiting in Texas, and we always try to convince the local authority to tell us the waiting list number in their local counties. I used to be the chair of the local DD Advisor Committee in Bear County in San Antonio, Texas. And no one is sharing the local authority waiting list number. But at the same time, I worry about people like myself, Tia, Liz, and many others who are living independent. I feel like we fall in between the cracks because we're not, like I said earlier, we're not being chicks no more. We are getting older and aging because our family passed away, or we get some family support, or even become our friends, because I count on my friends who support me because they're young, not young as me, they're older and they aging too. But my concern with the NFP process in Texas is only people from the institution settings, from moving from the institution settings to the community, but it's not filtered into the other waivers, helping others like ourselves. And I want to challenge CMS to challenge Texas and many other states to get people out the waiting list and really reinforce them you need to put more money to invest the waivers to get people out the waiting list.
Thank you, James. Todd,
Thanks.
any reply?
Sure, thanks, James. As you know, for Medicaid waiver or home and community-based services waiver programs, it's a federal and state partnership. So it's where CMS can work closely with the state to listen to what the advocacy community is saying, what the needs are, and to build a service system that really supports the needs over their lifetime. And as you mentioned, these waiting lists can occur where individuals are looking for, basic service needs. How can we support people with needs in the setting of their choice, with natural supports, with low-level supports to stay where they're currently living, or to help people to transition into home and community-based services from an institutional setting. So there's a lot that needs to happen. And as you mentioned, some of these waiting lists can be quite long, but it's important to ensure that your voices are heard and that you're able to access the supports when you need them.
Thank you. Okay, Liz, second question. Yes, please, or comment.
Thanks, Todd. Maybe I missed it, and I understand that you're focusing on aging. But what about children? We need not forget about them. We need to not forget about the youth.
Thank you.
Point well taken. Yes, home and community-based services and the needs of individuals, especially with developmental disabilities, is across the lifespan. So it's not just about adults or adults with aging caregivers, but also within the school system, EPSDT and other programs that are available for, children as they go through the system.
Thank you. We're going to move forward now to our next speaker. Thank you, Todd. And we're going to hear from Janine.
Could I say something really quick? I just want to say that I'll put in it's Jody. This is Jody Samaraki at CMS. And I just wanted to say really quickly, just to the point on EPSDT, that we just released some guidance related to that yesterday. And I'll send that link around to everyone so that they have that.
Okay, thank you.
Thank you.
Janine, please.
Hello, good afternoon. Thank you for having me today. Appreciate this opportunity to be here and to discuss a recent HUD initiative to increase access to affordable housing opportunities for individuals with disabilities. My name is Janine Lafrata, and I work in our Office of General Counsel in our Fair Housing Office. Next slide, please. Next slide, thank you. Our office advises on various federal fair housing and non-discrimination laws, including the Fair Housing Act, Title VI of the Civil Rights Act, Section 504, the Age Discrimination Act, Title II of the ADA, Architectural Barriers Act, among others. Our office also coordinates closely with our client office, the Office of Fair Housing and Equal Opportunity, in their investigations of complaints and of compliance reviews. What I want to turn to discuss with you today is HUD's Section 811 Mainstream Voucher Program for persons with disabilities. It's commonly referred to as mainstream vouchers. And I want to focus on this program because the department recently announced new program flexibilities to better reach eligible persons with disabilities access this important housing resource. So first, some brief background on the program. So mainstream vouchers are administered by HUD's Office of Public and Indian Housing, PIH. They're operated by public housing agencies across the country, and they're vouchers specifically for use by non-elderly persons with disabilities, and this includes individuals with developmental and intellectual disabilities. So eligible populations are individuals who qualify between the ages of 18 and 62. They are primarily tenant-based vouchers. So this means they are vouchers to enable eligible persons to find housing in their communities and to provide for integrated, supportive community housing opportunities. In this program, it's unique in that HUD encourages partnerships with health and human service agencies to help PHAs find eligible persons who can qualify for the program. Since 2018, HUD has awarded funding to support 50,000 new mainstream vouchers. Next slide. So funding for mainstream vouchers are typically awarded on a competitive basis to PHAs, and then PHAs may set admission preferences for the vouchers. So for example, a PHA may have an admission preference for their vouchers specifically for persons who are transitioning from institutional or other segregated settings, as well as a preference for individuals who are at significant risk of institutionalization. So for that reason, this program is really a significant resource to further the goals of Olmsted by offering opportunities for access to integrated housing opportunities in one's community. Next slide. So as I mentioned, I wanted to highlight a recent notice that HUD just published for PHAs who administer these vouchers. And really the purpose of this guidance is to provide PHAs with flexibilities in how they operate the program. The issues that are identified in the notice are designed to address the challenges that we know exist in getting access to this program. For example, becoming aware about the program, getting on the wait list, and then finding a unit in the private rental market in which to use your mainstream voucher. Next slide. Okay, so I'm going to walk through some of the requirements that we have in the notice. One of the chief changes that we are really excited about is increasing this minimum initial search term for your vouchers. So for individuals who are eligible and are participating in the mainstream voucher program, there is going to be a longer minimum search term. So usually when individuals receive a general tenant-based housing choice voucher, there's a 60-day initial search term to find housing. So this is the length of time that you're given to find a unit in which to use your voucher. We know that it may take individuals a longer period of time to get up to that lease stage, right? And we know that there are decreased voucher success rates, specifically when we look at utilization rates of mainstream vouchers. There may be difficulties, for example, in finding a unit that's accessible or that meets other disability-related needs that makes the search term longer. It also may take a longer period of time in order to find a unit that's near public transit or that's near accessible transportation. Or it may just take a longer period of time to go out and find an apartment, to visit, right? What are available units in your area? May take additional time to consider what kind of a unit would work for you and your family, or even to complete the application process. So really under this notice, that's what HUD is seeking to do with mainstream vouchers, is to increase this initial search term up to 120 days, providing more time for individuals to find housing that works for them. And this 120-day period will apply automatically for PHAs that are participating in mainstream vouchers when they give a mainstream voucher to an individual with a disability. Related, HUD is also requiring PHAs to automatically approve the first extension request that's made by a household. So what this means is if a household who's utilizing a mainstream voucher doesn't find a unit within that initial search term, as long as they seek an extension, a PHA must approve an initial request and offer at least an additional 90 days. And again, this is more time for a family to find a unit that works for their household. Also, in this transition period, a PHA must notify the family prior to the time when their search term will expire to remind them about the deadline, to let them know how you can ask for more time, and really to find out if the family needs any assistance with their housing search, hoping that through this process, it is identified if there are any issues and finding, for example, an accessible unit or a unit that otherwise meets a household's disability-related needs and what resources they may need in that process to better connect the household. Wanted to flag here that it's really important to note that these are alternative requirements that HUD is putting in place to help individuals throughout this process. However, regardless of these time periods, PHAs must always provide extensions as a reasonable accommodation, right, in accordance with HUD's requirements under Section 504. So an individual with a disability is not limited to initial search terms or even extension request deadlines that are set by a PHA. An individual with a disability can always seek a reasonable accommodation for more time that may be necessary. Finally, the last alternative requirement that I wanted to flag in this notice is the prohibition on residency preferences. So under this notice, a PHA cannot have any residency preferences for these vouchers. Now, because mainstream vouchers are intended to facilitate access to housing for individuals with disabilities, including individuals who may reside in institutional or other segregated settings, they may not be located in the geographic area in which they would like to reside, right, and to use their mainstream voucher. So a residency preference may prevent an otherwise eligible applicant from accessing mainstream vouchers. And so this prohibition is intended to get to that issue. Next slide. And then here I wanted to highlight some of the discretionary policies that are available under this notice. First, a separate waiting list for mainstream vouchers. PHAs now have the ability to adopt a separate waiting list specifically for these special purpose vouchers. We know that working off a general HCV waiting list for all of a PHA's tenant-based vouchers has led to some challenges for certain PHAs. For example, it can be difficult to find eligible applicants from long HCV waiting lists to figure out if you're eligible for a mainstream voucher.
Forgive the interruption. 1 minute notice, please.
Yep. So what this is intended to do is to link mainstream vouchers with eligible applicants as soon as feasible. Again, this is discretionary and it's up to a PHA. If they do decide to engage in a separate waiting list, they're required to provide effective communication of notice to make sure that everyone who's on your existing traditional waiting list has access to this separate waiting list. I also just want to highlight that the notice also encourages working with partners, referral partners, to help identify eligible applicants such as continuum of cares, independent living centers, area agencies on agency in order to find individuals who need this housing resource. Next slide. Here, I just want to briefly highlight again that the program must be administered in compliance with all federal fair housing and civil rights requirements. There can be no exclusion of individuals based on one's type of disability or on the basis of any protected classes. And again, of course, reasonable accommodations have to be provided throughout the program. Next slide. And then here I've just listed some resources on HUD's mainstream voucher program. If you want it for more information, a link to the notice that I walked through, the press release. Also through there, you can get a link to learn about more HUD assisted housing programs and activities. And then the last slide. While I focus today on our mainstream voucher program, I also just want to give an additional resource of HUD's FHEO website to learn more about federal fair housing rights and obligations. For example, physical accessibility requirements, such as under the Fair Housing Act and Section 504 for our HUD-assisted housing. Also a link on filing a fair housing complaint. And then 2 additional resources, the department's statement on the role of housing in accomplishing the goals of Olmstead, and our HUD DOJ statement on reasonable accommodations under the Fair Housing Act. And I encourage you to look at HUD's FHEO website for more information. Thanks.
Thank you very much. I see 2 hands. So first John and then James.
James can go first because I'm still trying to.
Okay,
figure
James,
out.
thank you.
I'm going to share something. I feel like we are a minority group in the HUD process. What I mean with that, I said a meeting a couple of months ago was a lot more people with physical disabilities were at the meeting, and they focus on people with physical disabilities, like grab bars and housing things to be easy for them. But they didn't really focus on people with ID and a disability, because a long time ago, I want to buy a house. But now the cost of housing is just too hard to reach. And how we could get people to think outside the box, not just people with physical disabilities. Because I feel like we are a minority, and sometimes they say, oh, that's nice, That's good. We want to hear your thoughts. Thank you. But they don't take it seriously. And I
Janine?
tried to convince the HUD and also the disability group I was involved with. I said, we're here too. We not just talk about accessibility, we need to talk about accessibility with transportation. If you live in a neighborhood where a bus or a paratransit goes there, and also it's also affordable if you want to live in a nice apartment and to feel safe in that apartment building.
Thank you, James. Janine, any comment?
Thank you very much for the feedback. I appreciate it. And yes, I think it's something that we're aware of. We consider as we are working on issuing guidance and how we think about, in particular, compliance with Section 504 of the Rehab Act and how we're thinking about individuals with various types of disabilities and not just individuals with physical disabilities. And you'll see that, for example, in FHEO issued guidance when we talk about reasonable accommodations and the examples that we provide so that HUD recipients are aware that an individual with a disability may request a reasonable accommodation for a variety of reasons. And it's not necessarily always going to be because of an individual with a physical disability. Just to go back to this notice, I know this is just one example, but what we've intended to do is, again, recognize that more weight, an additional search term may be needed, not just to find a physically accessible unit, but there are a variety of challenges or barriers that individuals with various types of disabilities may face in that housing navigation search. And so that's what that's intended to do, is to recognize that. So I appreciate it and thank you for the comment.
Thank you. And Sean, you have your question now?
Yes. So I always say this. Why don't it's any way, like, say if a multi-million, I'm just for the out there, billion company build a luxury apartment, right? And the units are nice and they are kind of expensive. Is it any way that her can work with the developer or the housing contractor? Cause I used to study real estate, so I know kind a little bit about this. Is there any way that y'all can sit down with these mega developers, say, okay, can you please set aside some of these units for nice housing? Because let's be honest, when we think about accessible housing, they not in the nicest neighborhood, especially for minorities that have disabilities. So, like, I want to see that real nice, shiny, brand new apartment that have a gym, a pool, accessible for those.
Thank you, Sean.
Oh,
Let's
yeah.
give Janine an opportunity to reply.
No, thank you for the comment. And I think it's a point well taken, and a lot of it has to do with, the various funding sources that go in, right, to different housing developments. And what are the eligibility requirements? When you're talking about HUD assisted housing, we have various different HUD assisted programs or activities, funded by Congress, and then that kind of dictates, right, who are the eligible occupants for the housing and set the income requirements. And there are absolutely, right, there's, you have public housing, right, on one end, and then you also have our voucher programs, which can be tenant-based, which is what I walked through today for our mainstream vouchers, or project-based vouchers, where then it's a certain number of units within a mixed development, right, where you have affordable and non-affordable units, and then a variety of other programs. Some of our multifamily housing programs that are targeted at specific populations, and then as well as our various homeless assistance or community development programs and activities, which really get to, again, community development in addition to just the hard units. So thank you for your comment. Appreciate it.
And we're going to have
you.
time for one other question from someone in our Zoom meeting room. Hillary, I understand you have a thought or a comment question.
Oh, thanks. I didn't know if we had time. Just quickly, the different, particularly the mainstream voucher program that you were talking about. So, is the processes and everything, I guess, the same for a person with an intellectual disability who requires 24/7 supports and supervision? Are the same resources available to that person who, because of their complexity and severity of their disabilities, they're not going to be living independently? So perhaps they would have to be living with the family, or maybe there are a paid caregiver part of it as well. How does everything that you talk about fit with that end of the spectrum of people with disabilities, with intellectual disabilities? Is it accessible to them as well?
Thank you, Hillary.
Sure.
Yes.
Thank you.
I know you can't see Janine, but she understands your question. Go ahead.
So these are tenant-based vouchers, right? So it's a voucher for eligible persons with disabilities and their household to then find a unit that works for them. And so the eligibility requirements are really set at if you meet the age requirements between the ages of 18 and 62, and then also having a qualifying disability, which again absolutely includes a range of qualifying disabilities. So individuals with developmental and intellectual disabilities are absolutely included, because it's a very broad definition under HUD's Section 811 program of who qualifies for this special purpose vouchers. And the idea behind it is, again, rather than looking at our general tenant-based vouchers, because they're special purpose vouchers for individuals with disabilities, it gives you that referral more quickly in some cases for PHAs to get the housing resource more quickly. And then in response to your more specific question about live-in aids, for example, again, that's all addressed, agree with you, through like reasonable accommodations, considering what are the needs of the household in determining whether how the tenant-based voucher will work in the community. But that's where you'd start is, again, what are the eligibility requirements at the outset, and if you're an eligible non-elderly person with a disability, and then you work your way through the wait list, you have access to the voucher to then find the unit in the community.
Thank you. And one of our ex officio members has a comment to add. Max? Is your microphone on? Is your microphone on? Thank you.
Well, two of the initiatives that the Justice Department has taken on to facilitate some of the initiatives that Janine and others have talked about. One is that we have tried to use the Fair Housing Act to establish that accepting tenant-based vouchers may be a reasonable accommodation for people with disabilities. So in other words, if you're receiving a voucher or any source of income that you're using to pay for housing because you have a disability, we have tried to argue to the courts that landlords have a duty to accommodate that by accepting the voucher. We have had limited success and some failures with that, but that is something we have been trying to do in cases across the country. Another is that we have brought Fair Housing Act cases on behalf of people with disabilities who, to live independently, require in-home supports and services, and that's being denied by landlords based on the different rules that may not allow that. We have tried to focus our fair housing work on those kinds of cases to help people with disabilities come out of institutions and live independently in the community.
Thank you. Thank you for that additional information. Janine, thank you very much. So we're moving along now, and we're going to hear about our last federal, from our last federal partner, education, and we have two speakers. So please introduce yourselves. Thank you.
Thanks, Robin. Hello, everyone. My name is Ashley Brizzo. I'm joined here by my colleague Shannon O'Neill. We will split our remarks and keep them both brief to allow plenty of time for discussion. Thank you for having us. We do have a few slides that talk about our mission, and we'll reserve those for reference to get to the meat of our discussion. So Wanda, if you wouldn't mind advancing, I think 3 slides, and then you'll hear from Shannon in just a moment. I can give you 1 more. Thank you.
No, one more, Wanda. Sorry about that. Okay, so Emmanuel and Jordan talked a little bit about inclusion and the importance of reducing segregation, not only in schools, but in our communities and the workforce. Their comments directly align to OSER's Inclusive Practices Priority, which addresses the need to improve access to and the quality of inclusion in our nation's schools. We know that when children with disabilities have access to a high-quality inclusive education, academic and social outcomes are improved, which leads to greater post-school success. The department released joint guidance with the Health and Human Services on the importance of inclusive programming in early childhood. We are now shifting to how we can provide guidance to support states, districts, and schools with providing a high-quality inclusive education to all children with disabilities. We are focusing our work on meaningful, individualized inclusion where educators have high expectations for both academic and social outcomes. When inclusion is meaningful and accessible, children with disabilities have a greater sense of belonging where they are not only included, but they are valued in their school community. This hopefully would help improve the quality of life statistic that we heard earlier about the 80% of people with IDD reporting a lower quality of life. So when you have that sense of belonging, the hope is that that improves the quality of life score or the statistic in that area. We want all people to feel valued. That's a crisis, if you ask me. And that's really where we need to be able to start by addressing that within our school systems. Next slide, please, Wanda. OSEP funds the National Center on Inclusion Towards Rightful Presence, which is a technical assistance center that works with states on improving our education systems for children with extensive support needs. Here's a quote that resonated with me that comes directly out of that center. Rightful presence in education is about co-creating an environment conducive to learning and personal growth through cultivation of a culture of true belonging for students and educators who historically are treated like guests in a system designed to serve a dominant or host culture. Powerful. OSER's Inclusive Practices Priority aims to cultivate the very culture of all children in all of our nation's schools, where that sense of belonging is inherent and part of what that system is designed to do. So I'm now going to turn it over. We're going to stick with the rightful presence theme, and Ashley's going to talk about that for post-school.
Thanks, thank you, Shannon. And yes, very, very powerful. Earlier, Lucy mentioned the value of friends through Best Buddies and Special Olympics. And thank you for sharing that, Lucy. In a recent exchange with a caregiver of my college best buddy, I was reminded of the strength and insightful and profound social connections that are threads in a beautiful tapestry of community. It was during a particularly difficult time in my personal life in college that my buddy Elaine 20 years ago was a source of empathy and comfort. And that's the strength of that friendship is something I will forever cherish. Fast forward a few decades, and new in my role at the Rehabilitation Services Administration, I'm forging new friendships with new colleagues. Hey, Shannon. Leveraging friendships from my former role and engaging in opportunities like today to connect and gather in community. And I say that to go back to the mission on the earlier slide as it relates to being integrated into the community. And I just want to illuminate the social component of that being a critical piece. Taken together, these old and new experiences affirm for me how vocational rehab serves not only to maximize gainful employment, such as the opportunities James mentioned earlier, but also how work can be a vehicle for belonging through weaving those social connections with colleagues. And on the next slide, there's a little bit of information about a current grantee. We heard earlier from ODEP about the Disability Innovation Fund. One particular project that I wanted to share with you is, it embodies this spirit of this social connection. The California Department of Rehabilitation's Pathways to Success project focuses on opportunities to prepare STEM occupations through career pathways and sector-specific specialist teams. Connecting individuals with disabilities, with intellectual and developmental disabilities to rehabilitation counselors and business specialists is a service delivery model that leverages common plans for employment. So people who want to do the same jobs, connecting them together. And I'm excited for this opportunity and this grant, this particular grant project, because I see it as an opportunity for pairing passions in a way that paves a path to not only find meaningful employment, but also fellowships with friends who have common interests. With a focus on STEM, this also is a great way of showing high wage, high skill, high demand careers and opportunities that can be had there. This project holds promise of pairing career choices with pathway pipelines and industries of interest. And just recognize that STEM may not be the career choice for everyone. I heard a call earlier of the call for transit and construction, so want to shout that out, Kelly. But whatever your interest may be, I just hope that passion paves that path. And that as Jane mentioned earlier, that there's equity within whatever that trade is. In addition to the grantee that's highlighted on this slide, earlier this month, we also funded a new cohort of Disability Innovation Fund grantees, and I wanted to share a little bit about that one as well. One of the grantees was the University of Ohio and is focused on employment capacity leveraged through inclusive post-secondary education. Eclipse is how they're referring to it. And it's a model demonstration project for a statewide network to promote competitive integrated employment and inclusive post-secondary education programs for students with intellectual and developmental disabilities. While it's at the very beginning stages, I'm really excited about what's in store for this investment as it relates to addressing the employment barriers and other barriers we've heard today. Thank you for the opportunity to speak, and it was a pleasure to share with you, Shannon, about our shared vision for rightful presence in the workforce and the world of social connection.
Thank you, Ashley. So I see 3 hands and we're going to try to keep it to 3. We're quite overdue for a break. So Brent, in our Zoom room, Brent to Liz to Tia. Brent, would you open your microphone, please?
Sure, can you hear me?
Yes, I can.
Okay, great. So my question regarding education is if there are any laws or regulations that mandate schools to conduct assessments of children whom they have reason to believe have intellectual or developmental disabilities. One issue we find here in our local school district is that teachers are discouraged from raising the issue or even discussing it with parents because the schools have to then pay funds and do the requirements that are 504 or ISPs.
Okay, so if I understand your question correctly, please stop me if I'm on the wrong track. But IDEA, the Individuals with Disabilities Education Act, does require that if anyone, so it could be the individual, the student's parent or guardian, could be a school staff, could be a pediatrician. There's a provision within IDEA around child find. So if there is a suspicion that a child has a disability, it doesn't matter which category, then the public school is required to review current information around what the concerns are. And as a team, they make the decision to on whether or not to proceed with an educational evaluation. So I guess the short answer is yes, there is the child find requirement within IDEA that does require teams to consider those educational evaluations.
Thank you. Liz?
Thanks.
Yes, and thank you. Thank you for bringing to the attention about belonging because I think that it's really important to belong as students without disability sometimes pick on people with disability. I had a horrible experience. On the other hand, I know some people did have a good experience. And I eventually had to go to a segregated school because nobody would ever want to sit by me at lunch. And in high school, and I cried the entire time. And I came home crying and complaining to my parents. And so my question is, and maybe a suggestion is to train teachers and principals and administration on how to include people with disability and include people in the community. And actually, I was thinking that maybe our next report should be about
Hold on to that thought, Liz. We're going to get to focus areas. Hold on to that thought. But Ashley and please.
Yeah, and thank you, Liz. And your story, your example is exactly why we have this initiative. We feel as though if we can create that culture of belonging in schools, that it's everyone. So of course, the educators need that training, the principals need that training, and that's really where OSEP funds our technical assistance centers, particularly that newer center, the one where that quote came from. That is exactly what they're doing. They're looking at the school level, the district level, because it can't just be one teacher. Of course, we want to start with a teacher, a single person, but it has to be bigger than that. So that's exactly what our work is focused on. So thank you.
And Tia, last word, we must take a break. Our ASL interpreter must take a break at this point.
Yes, my question is, what about people that want to go to college? I mean, I had to wait this long to be able to go to college. I couldn't transition from school to college because SAT, ACT testing, and I know that's been removed some because of COVID, but there's still colleges that don't accept people. And there's colleges out there that say they're disability friendly, but I didn't go to college for life skills to make my damn bed every day. I want to go to college for a career and to get a degree. And there needs to be more colleges out there accepting people with disabilities in a way that they can have a real career and really get the education that they need.
Thank you, Tia. Shannon, Ashley, noted. Any comment?
Thank you, and congrats on getting there now.
Yeah. All right. We are taking a 15-minute break. I'm sorry, Sean. 11:35. I didn't go into social services to do math, but I think that takes us to 11:50. Somebody check my math. We will be starting back promptly at 11:50. Support team, if you could let Greg Link know that he'll be on at 11:50, but we'll have him have his presentation done on time. 11:50. Take your break. Stand up. If everyone would take their seats, please. I know that 15 minutes went quickly, but we have two presenters in our next section of the meeting. So first, I would like to introduce Greg Link. Greg is the Director of the Office of Supportive and Caregiver Services for ACL, and Greg's going to be telling us about the RAISE Act, a national strategy to support family caregivers. Welcome, Greg, and thanks for your flexibility.
Absolutely. Thank you all so much. Good morning, everyone. And it is really great to be here with you to talk about the RAISE Act and the national strategy to support family caregivers, which we really believe is becoming a catalyst for change. In the time that I was on listening into the meeting yesterday, I was really heartened to hear the conversation steering into occasionally the need to understand and support the individuals who provide support to people of all ages with disabilities, many of whom are the family caregivers that I'm going to be talking to you about today. So if we could go to the next slide, please. So as the designated federal official for the Recognize, Assist, Include, Support, and Engage, or RAISE Family Caregiving Advisory Council, during the very first meeting we had of the council, one of the members, and this was back in August of 2019, one of the members articulated this vision for their work moving forward. How do we create a world where caregiving is central to who we are, as opposed to something that diverts us or is a sideline of our real lives? And I think that it was that statement that I think really helped to drive the work of the Family Caregiving Advisory Council that has led us to the formation of this national strategy to support family caregivers. And I know that it has certainly, my experiences as a family caregiver for my own aging parents has certainly shaped how I view the work and the importance of it. If we can go to the next slide, please. So I want to talk a little bit about the nuts and bolts of the national strategy to support family caregivers and how we got here. Next slide, please. So the RAISE Act, when it was passed in 2017, did not occur in a vacuum. It followed on many, many years of legislation at the federal level, congressional action, to better recognize and understand and support family caregivers. And that federal recognition of the importance that family caregivers play in the lives of those that they support really became evident in 2000 with the establishment of the National Family Caregiver Support Program and its component, the Native American Caregiver Support Program, as part of the 2000 reauthorization of the Older Americans Act that year. A few years later, in 2010, a similar caregiver support program was passed for on behalf of the veterans and their caregivers, these individuals who support our wounded warriors from all conflicts. But we've seen other significant pieces of legislation, including the Lifespan Respite Care Act, which came into being and was signed into law in 2006. And since 2009, ACL has been actively implementing that program through a discretionary grant program made to states for the strengthening and improving of respite care services for people across the age and disability spectrum. We also have seen, as I mentioned, the RAISE Family Caregivers Act, which was signed into law in 2018. It was actually passed by Congress in late 2017. The Supporting Grandparents Raising Grandchildren Act, which is a component, a companion piece of legislation that has also helped inform the development of the national strategy. We see the Families First Prevention Services Act of 2018, and most recently, Congress calling for the establishment of a technical assistance center on kinship and grandfamilies. Each of these pieces of legislation was an important milestone in the federal work that we do and in the mandate that the federal government has to recognize and support family caregivers. And the RAISE Act can really be seen as this piece of legislation that calls for bringing everything together so that we can look across the issue of family caregiving in a coherent and cohesive way. Next slide, please. So the RAISE Act, which was signed by the president on January the 22nd of 2018, has three key components. The first of which is the establishment of a Family Caregiving Advisory Council, which we did for the first time in August of 2019, and we seated a brand new council in 2023. The RAISE Act is very specific about who should be on that Family Caregiving Advisory Council. We have up to 15 non-federal members representing a variety of constituent backgrounds and sectors, including the healthcare sector, human services, state and local governments, but we also have older adults and people with disabilities on the advisory council, as well as family caregivers themselves. We also have a range of federal agencies that are represented on the council. The second component of the RAISE Act was the requirement that the Advisory Council deliver to Congress an initial report to Congress, which they did in 2021. And that initial report to Congress formed the foundation of the third component of the RAISE Act, which is the National Strategy to Support Family Caregivers. And later in my slide deck, there are links to all of these documents that I'm going to be talking to you about today. Next slide, please. So one of the key components of the RAISE Act was that everything that we do to develop that leading up to the publication of that initial report to Congress and the development and release of the national strategy was that it had to be informed through extensive engagement with the public, which we did. In 2019, at the direction of the Family Caregiving Advisory Council, ACL issued an RFI that in the Federal Register, a request for information that really asked folks to talk to us about what were some of the key challenges that family caregivers face, what are some of the success points that they're seeing, but also recommendations that they have for how we can develop policy and improve programs and strengthen our supports for family caregivers. We received 1,613 responses. 75% of those responses came from family caregivers themselves. From that, we worked with a close partner of ours, the National Academy for State Health Policy, who under a grant from the John A. Hartford Foundation, helped convene focus groups to dig a bit deeper into the findings of the RFI. They held stakeholder listening sessions with both aging and disability organizations and included stakeholder interviews with individuals representing state and county governments, employers, respite providers, community-based organizations, faith-based organizations, and focus groups of family caregivers and people with disabilities that they support. And all of this has been occurring and will continue to occur well into the future as we continue our work to strengthen the strategy. Next slide, please. So the national strategy, when it was delivered to Congress in 2022, consists of 4 components. The first, and there are links to each of the components here. Everything is on ACL's website. The first document is the strategy itself. It provides an overview and description of the strategy's 5 goals and the intended outcomes under each. We also talk about some first principles that the Advisory Council kept identifying these 4 recurring themes of things that had to be considered in everything that we do for family caregivers and those that they support. I'm going to talk about those 4 principles in just a moment. We also have a document that outlines nearly 350 actions that 15 federal agencies committed to in the initial iteration of the national strategy. And just last week, we delivered a report to Congress that outlines the progress that each of the agencies has made on their initial commitments. And then as a result of all of the public input that we received, the actions for states, communities, and others provides a wide array of ideas for actions that various sectors can take to better support families and family caregivers. Next slide, please. So the cross-cutting themes and considerations that kept emerging in the Advisory Council's discussions fell along these lines. The importance of placing the person and the person receiving support and the family at the center of everything that we do. The second is addressing trauma and its impact on families. We know that when there is a history of trauma, that can greatly impact both how services and supports are perceived, but also the extent to which we can benefit from them as a user of those services. And so everything needs to be grounded in this trauma-informed approach. We also kept coming up on this theme of being able to ensure that we're recognizing and advancing equity and support for family caregivers in underserved communities. Certainly, family caregiving is a very personal experience for every family, and those experiences then become much more varied as we begin to look at culture and ethnicity and how the role of family caregivers and caregiving is perceived. And then also we have to understand and address the severe direct care workforce shortage that we are in, because we know that there is an inadequate direct care workforce, an inadequate supply of these trained professionals to appropriately meet our needs. But we also know that family caregivers must oftentimes rely on the paid professional to aid them in their work and to support them. And so it really is a both and question consideration when we're talking about supporting family caregivers, as well as ensuring that we have an adequately available direct care workforce. So those are the four cross-cutting themes that filter across everything else that's in the strategy. Next slide, please.
Greg, excuse the interruption, but I need to give you a 2-minute notice so that we have time for the
Sure.
members to ask questions. Thank you for
Sure.
your understanding.
Sure. So if you could hit the enter button a couple more times. The strategy is a lot of things, and it's not a lot of things. The council envisioned the strategy as a roadmap for change, a framework for all caregiving situations and experiences. So in the strategy itself, you will not see specific conditions, diseases, or disabilities discussed at all. Rather, it is meant to address the breadth of the family caregiving experience and is intended for many stakeholder groups. It's not a how-to document. It doesn't contain any musts. As I said, it's not exhaustive of all of the possibilities. And if you can hit the enter button one more time, this is the first edition of the strategy, but it is not the last. And in fact, we are starting to work now on an updated version of the strategy. Next slide, please. We're going to skip this slide because it talks about the whole of society approach that is needed. There is something for all of these constituent groups in the strategy, and the actions that are laid out can be undertaken by any of these groups and sectors of our society. Next slide, please. We see it as a catalyst for change, and you'll see in this slide that since the strategy has come out, we've been able to build on a number of different and additional federal initiatives in which the strategy is helping to provide a framework at the national level. Next slide, please. And finally, we see the strategy as a framework for action. If you can go to the next 2 slides, you all will see these are actions that have been pulled directly from the strategy itself. These are intended to provide ideas for states, for communities, for the public sector, the private sector, to really begin to look at how we can better support family caregivers. And I'll let you read those on your own when you have time. Next slide, please. Next slide. There are extensive resources for supporting the implementation of what's in the strategy. All of this work has been funded by the John A. Hartford Foundation. And I encourage you to check out these resources that we have on these 2 different websites, because there's a lot there for folks to tap into to really aid in how they're using the strategy moving forward. I believe that's my last slide.
Thank you, Greg. Thank you very much. We're going to take questions from 2 citizen members. Liz, I saw your hand up, and then James.
And I know Joe is online. I have 2 questions. What we heard yesterday about the sandwich, I don't know, the sandwich issue between generation. Thank you. And how do you solve that issue? I haven't heard you talking about that, and that is a big concern. And then my second question is, what's the difference between caregiver and support person? I like the word support person, and I have heard people saying support for DSPs, and then you're saying caregiver. So thank you.
Sure. So the sandwich generation issue is definitely something that the advisory council is looking at, particularly when you're talking about family caregivers who are supporting both a younger individual, perhaps a child with a disability, or raising children without disabilities, but are also then providing supports for older relatives in some way or another. We recognize that that is a critical issue in terms of how the family members, the family caregivers are able to maintain employment, but also maintain their own health as well as support the individuals that they're supporting. It's not an easy issue to address, and I suspect that when we move into updating the strategy, that we may begin looking a bit more closely at the sandwich generation and those individuals that are in between and supporting individuals at both ends of the age spectrum. With respect to the difference between family caregiver and support person, the RAISE Act was passed and is intended to focus on the unpaid family members and friends that step in to provide support. Hence, we use the term family caregiver. But we also are recognizing that there are different, that relationship is often called different things. It could be called care partner, support person. It really is up to the family unit and to the dyad, the individual providing support and receiving support as to how they want to be referred. And we are looking at those very differently than we do the paid direct support professional, which is a profession. It should be recognized as such with the benefits and the training and the compensation that goes along with that. But we also know that together, the unpaid family caregiver and the direct support professional, we have to consider them together as how we provide the array of long-term services and supports that are needed in this country. So hopefully that gets
Thank
to
you,
your
Greg.
questions. Sure.
Thank you. James, briefly, and then Joe Macbeth, you'll get the last question on for Greg. James?
Greg, I have a question. For those of people we know, as far as a person experienced that I don't have no family, what's the word I'm looking, family caregiver in my life. And I'm worried about those people fall into the cracks, don't have a family caregiver. They count on the system so much of direct care or support people, wherever we use, what type of term we use, because I count on friends to help me, assist me. But at the same time, my friends is aging out. You know what I'm saying? People getting older, they could pass on. And someday I will be really alone. But I'm not putting myself down. But I'm thinking of others who don't have that skill or advocacy skills. No one teach our peers about how to deal when a caregiver is no longer be with them. I feel like we need to address that, how to deal with that type of grief, because I thought my real mom would be with me forever, but she passed away when I was only 17.
Thank you, James. Thank you. Greg, just a response, if any?
You bring up a really, really important issue, James, and that is, we talk about the aging of family members and other individuals who are supporting people with disabilities. And as both the person providing the support and needing the support age, it becomes increasingly more important to think of who's going to provide that support to you when the one who's been doing it is no longer there or no longer able to do that. That is definitely something that the Advisory Council has begun looking at very closely and will continue to look at very closely. The need for self-advocacy and training people to be their own best advocates is also critically important. And that's another area where we are doing some work to actually train both family caregivers and the people they support to be their own self-advocates, to be able to know how to speak up and what to ask for and what to look for. So hopefully that gets at your question.
Thank you. Joe Macbeth, last question or comment.
Thank you. And Greg, thank you for this presentation. My name is Joe Macbeth, and I'm the CEO of the National Alliance for Direct Support Professionals. A couple quick questions. We get contacted often by family caregivers from states who are paying family caregivers, supporting their family members with IDD. And seems to be a sense of frustration when they become targets of investigations when another paid professional sees that a paid family caregiver isn't following a plan, for example. And targets of investigations, allegations of abuse and neglect in the household from a family caregiver. And then it even goes up beyond that. A lot of family caregivers who contact us, I'm not saying generally, are concerned about timekeeping, record keeping, things that are not intuitive to a family member, but is part of a professional relationship. So there's a lot of gray areas and blurry lines between caregiving from a family member and a paid professional. How can we clean that up somehow?
That's a great question. And I think, we have seen that those frustrations and those challenges more and more as we have moved to more and more person-centered and consumer-directed approaches for services and supports, and that programs, that provide support are recognizing that there are not enough paid professionals to be able to do the work. And so they have to find, ways of funding that support, perhaps by paying family members and friends. And a lot of that, I think, I agree with you. I think that the family caregivers who are pulled into that or who do that type of work are oftentimes, they're overwhelmed by the requirements. I think we need to look carefully at how programs are administered, and the requirements that are placed on for reporting, for record keeping, if there are training requirements, making sure that they're actually feasible and reasonable, so that, paying a family member or a friend doesn't become a disincentive to providing supports. We have a long ways to go. I fully admit that, but it's something. I thank you for bringing that question up.
Well, and I thank you for that
And
answer.
Joe, I'm sorry, we don't have time for a follow-up today. I apologize. Thank you for your comment and question. Thank you, Greg, again, for your flexibility and your presentation today. We're moving on to the next topic, and we're going to hear again from Diana Caldwell, who's the Vice President of the Lewin Group, and Diana is going to be telling us about the Living Well grants. Thank you, Diana.
Sure. Thank you so much. And I know we need to shuffle around here a little bit, so I'll go ahead and get started while Wanda tees up our slides. And Wanda, you can move forward to the one that says background. I'm going to put on a different hat than I had on yesterday when I had a chance to speak with you. And today I'm here as a member of the evaluation team for a set of AOD projects of national significance grants, which we call Living Well for short. The long name is up on the screen for the grant program. And these are grants that are addressing health and safety and community inclusion. And so I'm going to share some findings from our evaluation. So we can go forward. Okay, so this slide contains a lot of data that we discussed yesterday and is well known, so I won't spend a lot of time, but really is illustrating the shift over the last several decades from institutional towards home and community-based services, and highlighting just a few of the benefits of community living. We can go to the next slide. We also know, and this came up throughout our conversation yesterday, that there are some risks and challenges of community living. So, for example, respondents to the National Core Indicators IDD survey, more than 1 in 5 people said they have felt afraid in one or more settings, like home or the workplace. We also know that people with IDD are more likely than people without disabilities to experience abuse and neglect and exploitation. There are many reasons for this. At the individual level, people can be isolated. People may fear retribution or knowing that abuse is often perpetrated by somebody the victim knows. They may be fearful to report abuse by somebody who they rely on. Reporting can be a challenge for a variety of reasons. At the system level, we know that systems are complex, they're siloed, they can be challenging to navigate. And some of the work that precipitated these grants back in 2016 or so, the OIG did some investigations and issued reports about states that didn't at the time comply with federal rules for reporting and following up on critical incidents. So I'm just hitting the tip of the iceberg here, but I think we teed up this conversation nicely yesterday, so I'll go on. So the purpose of these grants, we can go to the next slide. The purpose of these grants is to increase community integration and independence of individuals with IDD and to improve the quality of home and community-based services. And next slide, please. The approach for these grants was to address two interrelated core components. And I think this is another area that picks up nicely on some of the themes from yesterday, and that is you can't necessarily separate these issues of community monitoring, of monitoring for health and safety and well-being from building capacity in the community. So we can't talk about ensuring that somebody is healthy and safe if we're not also talking about the capacity of provider organizations, for example, to support somebody in that. So grantees were to design one or more model approaches that addressed both of these components. So the idea was that grantees would develop projects that could be scaled or replicated. Next slide, please. I'm not going to read off all the grantees. There are a total of 8 in 2 cohorts. The grants were 5 years and many of the grantees received extensions. So the grantees are all finishing up their work just about now. So we have a lot of data and a lot of lessons learned. Let's go forward 2 more slides, please. All right, I want to highlight 3 areas from our evaluation findings that I think might be of interest to this group in terms of how the grantees approached these 2 interrelated issues of community monitoring and community capacity building. So grantees took system-wide approaches to really affect change across their statewide systems. Grantees focused on increasing knowledge and awareness of these issues, and then grantees also focused on building the capacity of self-advocates. So let me talk first about systems change. We'll go to the next slide, please. So early in the grant, most of the grantees kind of took stock of their systems, and there were some common challenges. Most systems of community monitoring include multiple agencies, multiple systems, and oftentimes they're siloed and they're fragmented. There might be inconsistent definitions of abuse or ways that abuse and neglect are tracked and reported across systems. A lot of states collect a lot of data in this area, and sometimes it just kind of sits and isn't used. Also, sometimes data isn't made available to those who need it. And so I'll highlight just a couple of grantee examples. The Idaho team had an existing statewide group that advised their health and welfare system on community living. And so they were able to align their Living Well grant with the recommendations of this system. They used a work group structure to bring forward recommendations and work on project priorities. So among other things, they advocated for a centralized agency to which people could report abuse and that would monitor abuse and neglect. They also advanced recommendations for a caregiver misconduct registry and having a centralized reporting number, so you didn't have to call different numbers to report adult abuse or abuse of an individual with a disability. Wisconsin is another great example, and they used kind of a two-pronged approach where at the statewide level, they developed recommendations. And then they also piloted a program with 8 provider sites. And among other things, they worked with those provider sites and the staff to look at their own policies, to make sure that the staff understood what is abuse and neglect, what is rights, do we have the right procedures in place to support individual rights. Next slide, please. The next item I want to touch on is increasing awareness. Some of the issues that grantees encountered were an underreporting of abuse and a need to build capacity for people to live in the community. Grantees really attacked this at all levels. Alaska took a broad approach where they developed public service announcements. So among other things, they had videos posted on Facebook that were aimed at raising awareness among the general public around what is abuse and neglect and how do you report it. Also, grantees worked with provider site to build awareness and knowledge. I touched on this earlier, and also worked with individuals to build awareness among individuals with IDD so they know their own rights. They know what abuse is, how to identify abuse, and how to report abuse, as well as engaging self-advocates who could help to work with peers and educate their peers. And next slide, please. The third area I'm going to touch on is self-advocate capacity building. So some of the issues that grantees identified or the challenges was that sometimes individuals with IDD don't necessarily understand their rights or need support in terms of communicating their preferences or their wishes, what they do and don't want to others, understanding abuse, and also understanding what healthy relationships look like. And so grantees engaged in a number of ways to address this and support self-advocacy. Another success coming out of the Idaho team, they created the Culturally Responsive Advisory Group. This is a group primarily of Latinx members, many of them family members of people with IDD. And this group really grew throughout the course of the grant and ended up being asked by the Medicaid agency to consult them on how they could be improving their systems, particularly for the Latinx community. And Wisconsin, I actually mentioned them yesterday. They developed a series of guides. They're available online and accessible, and made those guides available, and also used self-advocacy training program where they worked with advocates to go out and provide this training in communities, and found that to be really successful. So I went through that very quickly, recognizing that I'm standing between you and lunch, but I'll pause there. The grantees have done a tremendous amount of work, and this is documented in some other reports, but happy to answer any questions.
Thank you very much, Diana. I see your hand, James. Let me just see. Very good. James, you're first.
What about group homes in institutions? Why you guys did not, by the way, people in institutions and group homes of being safe? Because I know a couple of situations that they failed to do. I don't know you was in the room yesterday or not, but I share my concern about 2 different people, and one who needs them to be investigated, they didn't do it. But at the same time, the person did not need it. They investigated a full-length investigation.
Yeah, I think you're raising some of the things that really prompted AOD to issue these grants, and you're highlighting issues that these grantees are looking into. A tremendous amount of work has been done, but there's still a lot of work left to be done. There's progress being made, but I appreciate your point and recognize that there's certainly a lot more to be done to address issues of health and safety.
Thank you. Tia?
I know there's professionals that go in and talk to people with disabilities in many places, but it would be also helpful if you use self-advocates to go in and ask questions. It's a different, that peer-to-peer support is much better. I know that when our Department of Human Services asked us to do on a case, on a class action lawsuit about talking to people if they were moving out, what was happening there. Even the people that work there were more at ease to talk to people with disabilities about those issues and about what was happening. They didn't feel threatened. And you can get many self-advocacy groups to go in and do this work, where you get actual people to ask the questions to other peers and other people that work there about what's really going on. Because sometimes I know protection advocacy has a right to go into different institutions and places unannounced, but they know when they're coming. I mean, they big time know when they're coming. They have secret code words and everything. I saw it live myself of when they know when they're coming, and to straighten things out and to take people on outings that can talk and say their mind when they've never been out. So what would you rather do? Go on an outing that you've never been on, or stay and talk to some public officials about what your situation is?
Just so, Liz, I see your hand, so go ahead. Diana, any comment?
Yeah, that is a wonderful suggestion, and we did see some of the grantees are doing that, but that's certainly a really important point and something that should be, carried forward.
Yes, Liz.
And going on to his point, I know in Maryland there used to be a grant that the self-advocates would go into two places in Maryland. And then the other example I wish showed to you is I used to work for an organization that would go in and review programs. And you might have heard of the Council on Quality and Leadership. And one quick story, when I first started doing reviews, I went with someone to train me to do this, and the person stopped, and my colleague stopped in the middle because it was evident that the person with a disability was more interested in talking to me and would trust me better than trusting the other person, no matter whether we had the same kinds of questions, we're trained the same way or whatever. But I know the person. Well, I might not know exactly what the person's story is, but I know what it feels like to be in that person's shoes.
Very
So
good,
thank
Liz.
you.
Thank you.
Yeah, thank you.
Wonderful work this morning, everybody, into the early afternoon. Thank you very, very much for all your understanding and participation. So we're going to have one topic when we come back, and then it's going to be all about you. And we're going to have time to sit back, reflect, and think about the future. So we will start back promptly at 1:30. See you then. Thank you for returning back to the table. Citizen members, back to the table, please. Thank you very much. Our presenter for this afternoon is a former coworker and colleague of mine, Janine Zalaki. Hello, Janine. Janine is the Director of Technical Assistance and Special Projects at NASD's, and Janine is going to be telling us about some innovation related to the advancements in access to technology solutions. Good to see you.
Same, Robin. Thank you so much. Next slide, please. Well, good afternoon, everyone. I am delighted to be here. As Robin said, my name is Janine Zalaki. I'm the Director of Technical Assistance and Special Projects at the National Association of State Directors of Developmental Disability Services, which you may know us by NASDs, and you heard from our Executive Director yesterday, Mary Sowers, about the Link Center. My visual description is I am a white woman with blonde hair and wearing a black and white striped blouse with a black jacket in front of a blue NASDs background. My pronouns are she, her, and hers. I would like to first start out by saying that I'm honored to be here today, and I want to thank the chairman of PCPID and all the committee members for having me here to discuss technology and how essential it is for all to promote self-determination and engage meaningfully in communities. Before I start, I also want to acknowledge that technology has been a priority for this committee for quite some time, as I can see, raising topics such as improving technology access and design for people with intellectual disabilities, promoting the use of technology solutions and long-term services and supports, and hearing yesterday about the most recent report and a recommendation to leverage technology solutions. In the essence of time, I'm going to skip the next two slides so you can go forward. You can read about NASD's efforts. Thank you so much. Perfect. So I can't really focus on technology without discussing quickly the impact of COVID-19 on technology. The COVID-19 pandemic was so very devastating. And during that pandemic, though, the state DD agencies were kind of thrust into reevaluating the use of technology and technology solutions by having to really rely upon innovative approaches and emerging technologies to address the needs of people with IDD and their families and receiving services through virtual delivery. It was really the catalyst that allowed for the investments in technology, as technology solutions during those 2 years, as you all know, frankly, were the only solution. Next slide, please. I'm going to focus my time today on the Technology Solutions Survey 2.0, which is about program and service innovations for advancing access to tech solutions. This was done in the fall of last year in 2023. NASD's in collaboration with Dr. Shay Tanis from the University of Kansas, State of the States, who tracked national longitudinal data on technology first and access to technology solutions for people with IDD and their families, and who you all heard from yesterday, Dr. Tanis. So we launched the Technology Solutions 2.0 survey, which we had 40 states that participated. So we were really happy and excited to have that many states. We set out to set the landscape for the discussion of state technology data. And we really wanted to compare the data from our 2019 survey. So we did one survey before this one, and that was the first one, to this solution survey in 2023. Definitely, it was right after the throes of the pandemic, and we focused on 3 primary areas. One was funding for technology solutions. 2 was operational specifications, and benchmarking for systems change was the 3rd. So I'm going to briefly talk a little bit about each of those areas. The first, next slide, please. The first section that we're going to talk about is funding for technology solutions. Next slide, please. So states providing funding for tech rose by 20% in our new survey report. So we felt that that was pretty significant, a significant jump. Home and community-based service waivers remain the dominant funding vehicle, with 93% of the states that responded to our survey listing the Medicaid home and community-based services waiver as the primary authority used to purchase technologies. Followed by 50% of our states listing vocational rehabilitation as the authority to purchase technology for employment supports. And then there were other funding authorities that were mentioned, such as state plan, 1915I services, and state-only general funds. Those are state-only funds where states don't get the federal match on. We also saw that there was an increase in the use of technology infused by state ARPA funding. And this was used to purchase devices, systems for data management, the use of telehealth, and also incident reporting in states, just to name a few of the ways that states have used those funds. Next slide, please. The next area that we focused on was service or operational specifications. And I want to note that the specifications, there's a myriad of terms being used across the country for technology. And I'm gonna go over a few of them with you that you may have heard of or talked about in your states, but there's no consistency. Remote supports through this survey has gained the most popularity as a technology solution due to a couple of factors. One, remote supports have been in existence in some states before the pandemic. Also, remote supports, it's been proven that there's some cost efficiencies. But the most important part of remote support use is the demonstrations of personal growth for people through interdependence. So, and not always having to rely on staff. We talked a lot in these 2 days. I've heard a lot about the direct support workforce crisis, and remote supports is also another creative solution. I want to make sure I say that it's not technology only. And this is for remote supports for people who have really expressed an interest through person-centered planning. And the use of remote supports has also paved the way for creative rate structures, broadband access, and training opportunities. In fact, 41% of the states that we surveyed use remote supports, and they use them in places like supportive living. And that increase was from 2019 to 2020. There was also a 29% increase in remote monitoring supports in general from 2020 to 2021, giving us a total of about a 41% increase in those 2 years. So I think that's probably the most significant piece of data that I would offer on the operational specifications today. Next slide, please. I mentioned to you all that there is a vast amount of terms being used across the country, and no two definitions are really the same. Remote supports you might hear of it called remote monitoring, have really gained popularity as a tech solution, as I noted. We also found that states throughout the pandemic were starting to ask CMS through their waiver amendments if they can provide waiver services through what I'll call virtual delivery, two-way communication, providing that service virtually. Telemedicine has always been an option under the state plan services, as well as telehealth, but sometimes those words are used synonymously to mean other ways of providing supports, that virtual way or through remote monitoring. So these terms are kind of going about throughout the country and being used in different ways. You are always able to meet with your doctors without coming into the office using telehealth. So telehealth solutions is kind of the overall term that we're using to really capture technology use, as well as the term enabling technology. Talking about enabling technology as a whole it's a really innovative way to support people in their homes and around their communities, in their work, to become more self-sufficient using various off-the-shelf and sometimes customized technologies. These are all done in a person-centered way. Some people use use remote supports for some of their day. They have other services that they utilize in person. It's really person specific based on that person's individual needs. When utilized in a person-centered manner, these technologies have a substantial influence on long-term services and supports, and assisting people in a more natural, definitely non-segregated environment, with the whole goal of independence, personal development, and additional opportunities for self-determination. When we think about technology in waivers and supports, CMS too is always interested in, who is providing that service? How is that service being provided? Where is it being provided? And what are the goals of the service? How about the equipment? Does the person understand and know how to use that equipment? I know there was a comment from a committee member yesterday about, having all this technology, but if someone can't use it, how useful is it? And that's certainly an astute point and something that we don't want to happen. Next slide, please. The third area of our survey was really looking at benchmarking for technology first systems change, because a lot of states don't have a lot of data or benchmarks, but there are some states who are now starting to look at what are the increases in technology. Technology first began as a movement, but has really transformed into a framework for systems change, where technology is considered first in the discussion of support options available to people and their families through, again, person-directed approaches. So it's not, again, I want to emphasize that it's not technology only, but a lot of states are introducing through their person-centered planning processes, having that tech discussion. There are 18 states that are engaged in technology first activities. I'm not going to name them all, but I'll name a few: Ohio and Tennessee and Missouri and Colorado, North Carolina and Indiana, just to give you a little idea of a couple states, but there are a total of 18. Next slide, please. So what kind of technology first activities were states participating in? Might be on your mind after listening to some of our data. Number one is modernization or harmonization of policies to support technology access. One example I'll give you is Maryland's Inclusive Housing Assistive Technology Navigator. That was developed in partnership with Maryland DDA. And the Assistive Technology Navigator is really a resource list which will assist people to think about how technology can make living on their own a possibility. The second activity states have been participating is regularly convening a statewide group focused on technology access, services, and programs. And this is with people with lived experience using technology. Maybe it's a tech first council to understand, what promising practices there are and what are some of the needs and gaps in that state. Another activity is consideration of technology solutions as a required conversation, as I noted in person-centered plan development. Missouri has an assistive technology as well as remote support sections of their individual support plan. And this is to ensure the conversation is had and people have access and they can make an informed choice about their interest in those services. Another is pilot programs for evaluating the impact of technology for people with IDD. California requested input into the design and evaluation of a tech-first pilot program to test whether remote supports could help people lead more independent lives. They didn't want to jump right into it and add it into their waivers. They wanted to do a pilot and learn from end users to see what kind of alterations needed to be made for that to be successful in California. Statewide evaluation of technology needs, statewide data collection or protocol for impact evaluation. And an example would be Ohio identified technology indicators to promote the use of supportive technologies. And they had a goal to educate people and to increase remote supports by about 15%. And they had a very strong statewide campaign of education and outreach, and they ended up increasing it by 40%. There was, an increase in 40% of end users who were really interested in having supports by remote supports and not having someone with them, as many hours of the day as that they previously had. Statewide capacity building for providers and end users. We also heard yesterday that there's a real need for direct support professionals and providers and end users to get that education. Missouri wanted to promote remote supports as well for increased independence and also a reduction in the stress levels of overall the DSP workforce. So the state had a program for savings for the providers who did have and implement remote support. So there was a 15% of the state share in savings that would go back to that provider to invest into that service and the direct support workforce. And then communication strategy for sharing technology first efforts. So focusing on real people, real technology success stories that could really help shape the communication strategy for all and to understand some of the possibilities. Next slide, please.
And Janine, excuse the interruption, but I'm going to need to ask you for a 2-minute summation so that we have time for our members to ask questions and comments. Thank you.
Absolutely. You're welcome. So quickly, challenges. With all that being said, there's a lot of different challenges in implementing and scaling the use of technology supports. I already mentioned inconsistent terminology. There is a variation in policies across the country and HCBS populations. There are payment barriers. There are a lot of misperceptions regarding Medicaid covered populations access, and there are data limitations. Next slide, please. So how do we support technology moving forward? We want to increase funding vehicles and Medicaid authorities and to be more refined about technology. We want to get that terminology alignment. We want to establish data and tech-first benchmarks so we can evaluate the success of any technology initiative. Next slide, please. We want to conduct targeted educational campaigns, to understand where technology is being underutilized and how technology can be a best practice model. We want to increase professionals beyond case managers' understanding of tech services, so they can push the tech agenda and educate professionals for the use of technology. We want to integrate connected technologies with the aim of increasing independence. These innovations are just a great involvement in the provision of HCBS. We want to ensure process standards that provide equitable access within the waivers to reduce equity barriers to enabling technology services in people's communities. Next slide, please. And lastly, we want to provide grants for the development and implementation of new HCBS business models. And then lastly, support innovative technology projects through the award of innovation grants that enhance, expand, or strengthen HCBS. And that is my quick summation, Robin. Thank you so much, and I'd be delighted to hear
Janine.
feedback.
Thank you, thank you. So yes, members, let's see what questions and comments you have. Santa, let's hear from you first, followed by James.
I have
I have heard. I have heard that.
Having a little trouble hearing you.
I have
I
have
have heard that if a person needs his doctor, no, a person needs. Oh, if a person needs a technology, you have to wait until after high school to get equipment because the school won't. The school won't. No. It would. Oh, it would buy equipment, but after high school, it's not the person's. That's the problem.
To make sure everyone heard, especially you, Janine. So Santa's talking about the availability of technology and equipment after high school, most equipment and technology provided through the schools before that point, but wondering about technology availability after high school.
Thank you so much, Santa. You raise an issue that we're hearing a lot about, and we also heard a lot about during the pandemic with school systems and what you can receive through, EPSDT and habilitation versus what is the school providing. What I want to say is if a person is receiving supports through a waiver, even when they're in school, because a lot of states do provide waiver services for people who are still in school. You can receive, if your needs warrant, assistive technology, communication devices, and some of the other technology that is covered through waiver programs. But the issue is that technology uses and access isn't applied consistently across these different programs. So that collaboration is necessary. And I also want to say to you that CMS is a wonderful partner, and technology is something that they are very interested in and committed to working with our associations to kind of work through some of the access issues. So thank you, Santa, for your comment.
James?
I have a question. How do we know what states is doing it and what states do not do it? I live in Texas.
Oh, okay. James, I'd be happy to share with you some of the Tech First states and some of their websites, but I can tell you that probably across the country, almost every waiver definitely would have assistive technology, home and vehicle modifications. They're usually some standardized services. It's just states are now starting to add in services such as remote supports to their waivers.
I just wonder if Texas is one of them.
While we're talking, let me,
All right, we'll
That
queue up the next questions, Janine. Hopefully you can multitask.
yeah.
Sean, we're going to go to you, then Emmanuel, then Liz. And Liz, you're going to get the final question.
Hi, I just want to know, since we on the topic of technology, had y'all been looking into AI in the benefits of law in the benefits that can have for people with IDD? I know there's some good things and not good things about artificial intelligence, but I wanna have y'all at least been thinking about the benefits
Yeah.
of that.
Yeah, let's hear from Janine on that. What are your
Okay.
thoughts, Janine?
I do want to just quickly, Robin, tell James that
Yeah.
Texas is not a technology first state, so that's something to definitely work on. And to answer this last question, boy, you are definitely ahead of the technology curve in HCBS. I agree with you. Artificial intelligence is really taken over the forefront of technology. We want to be very, very mindful about how that's approached from an HCBS perspective. I'm hoping as we have these conversations with our federal partners moving forward, we can discuss how our artificial intelligence would fit into an HCBS architecture, but we're just not there yet. But I agree with you. I use it so much in Zoom right now as well.
Emmanuel and then Liz. Thank you, Sean. Emmanuel?
I don't know if it's so much about a question, more of a comment. I know that Delaware is really looking at making sure technology is part of their plan, because I happen to sit on the advisory committee for DDS. But I also know recently Highmark, which is a provider, has partnered with our Center for Disability Studies, our DATI centers, to put technology part of people's benefit packages for their MCO, excuse me. Has there been conversation about the continuation of not only Delaware, but approaching other CMS providers about putting that technology piece in the benefit package? And if so, how can we get the provider to not only look at technology as a medical necessity, but also to decrease social isolation, so social connection, et cetera, et cetera.
Thanks so much, Emmanuel. I noted a couple of tech first states, but I also want to say that states are in the driver's seat for adding services to their waivers. So that advocacy about technology is really, really important from the grassroots efforts. But states do have the discretion to decide what services they will add to their waivers. I'm happy to hear that Delaware is leading out front there, and hope that many, many more states follow.
Thank you, Janine. Liz, we're going to give you the last question comment on technology.
Yes, thank you, Janine. My question is.
Thanks, Kathy. Yes.
My question is, with technology becoming more and more available, especially after the pandemic, is this like the Employment First initiative that was probably 20 years ago, that everyone was for employment first, and you were trying to be your state having employment first. Is this like that? Thanks.
It's an astute connection, Liz. I think that this effort is starting like that effort. But just like employment first efforts in states, it's not employment only. So same with technology, really has to be done in a very thoughtful way, according to a person's individual needs. But this is how those kind of efforts start. A couple of states leading out in front and then others wanting to join. So it was a very astute connection.
Very good. Janine, thank you very much. Great to see you. Thank you. All right. So members, we now have the rest of the meeting. This is your time. We're going to be seeing, rather than the PowerPoint, we're going to be seeing all of our virtual members on the screen, so they feel like they're in the room with us. And hi, Joe. We're looking for your aha moments. We want you to take a minute and reflect about the past 2 days. What are you thinking about? What are your takeaways? We'll start broad, and then ultimately we want to hear what you think should be on the table for consideration for future focus areas for your committee and for the next report. So I see a lot of eager people, and Paul, we haven't heard from you today, so please.
Sure. Thank you very much. And first of all, I guess I'll use the opportunity to say thank you. Thank you to you, Robin, for having the unenviable task of sort of keeping us on track. Really appreciate that. Jennifer, David, Chairman, everybody who's involved putting this together. It's been a really wonderful experience. You know, I'm sure you know, like a lot of, if not everybody on this committee, you know, I've enjoyed my experience being here for the last 2+ years, and the conversations and the meetings and the work. Being here with my partner, you know, we work together well. But being together in person is just, it's been really tremendous. It's a wonderful opportunity. The presentations were great, but the dialogue has just been so wonderful and so, you know, rich and you know, and inspiring. And I personally want to just thank, you know, all of the colleagues that share personal stories, some of them difficult ones. It's not easy to do, but it's so important that we share those. So I've really enjoyed this experience. I just want to put it on the table now, you know, in terms of going forward with future reports. I have 2 suggestions, if I may. One is, and I think Joe or somebody mentioned it yesterday, that maybe we should be more focused in our reports going forward, maybe take on single topics, maybe not, you know, spend the year or 2 years doing it, maybe shorter period of time, but just more focused. And in that context, you know, I want to put out there, you know, something we discussed a little bit yesterday. I would love this committee to focus on abuse and neglect. You know, we heard some colleagues share some really personal, compelling stories with us. And I can tell you from my own experience in New Jersey as the ombudsman, you know, as I've told you, and I've shared with all of you, you know, this is what I deal with on a daily basis. As you know, some of you know, I do an annual report that goes to our governor, and I email it to you guys, so I force you to read it. But you know, each year for the last 6 years I've been in this position, increasingly it's become to my attention the abuse and neglect that goes on, and I'm sure New Jersey's not alone.
No.
It's, you know, it's a dirty little secret that so many of us know about, but so few want to talk about. And I think it would be so powerful for this committee to do a report to the President of the United States, calling out the abuse and neglect that exists, explaining what it is, where it is, why it is, and then putting forward some strong recommendations on how we can eliminate it once and for all. to me, I think that would be such a great service to the country. It would be a great service, obviously, to the disability community. So again,
you.
thank you for this opportunity. This is really,
Yeah,
really wonderful.
thank you, Paul. So who wants to add? Yeah, Sean.
Greetings, everyone. First all, Ms. Warren, thank you so much for facilitating this meeting. Mr. Chairman, Dave, Sarah, Census, Ms. Wanda, and the whole support team. Thank you very much to my fellow wonderful, awesome, amazing PCIP members. I love y'all so much. But I do want to add Paul. Like I think that's focus should be on creating a report that can outline the needs for a special abuse unit within the FBI or the Department of Justice or wherever that needs to be housed at to address the neglect and abuse that go on by staff, individual, family members, and expose the hardship that people with IDD go through. And I think I would love to be the co-chair. All that again with Paul again. But yes. And also I think we also need to focus on getting a medical curriculum together for medical students.
Great.
Just like Mr. Chairman says. So that's it.
That's great, Sean. So we're eager to hear members agreeing with topics that are being raised and also bringing up new topics. So I know several of our members online are interested in talking. I'm going to go to Liz. Then I think that's you, Hillary. Is that who's it? Hillary, great. Your name's not there. So Liz, then Hillary, then Emmanuel. I promise, James, we'll get to you. Let's just get those three first. Liz, Hillary, Emmanuel.
There's 4 things I think I have heard this or that I think was very important to the last day, the last 2 days, and I echo the thanks for everyone. One is on transportation. If I can't get to work, then how can I get a job? And if I don't understand, or if I get 14 cents an hour, if we don't take away the 14C, the sub-minimum wage, and we only get 14 cents or whatever I didn't even know how much I got in the workshop, as I told you yesterday. So I'm just guessing 14 cents an hour. How can I afford the Metro ride or the Metro bus to get to work every day? And I'm sure that it costs $1 or whatever every day to get from my house to my work or even here. In education, I only got a high school diploma, and I want to be an advocate well, I think in my heart I'm a lobbyist. I mean, I don't have a piece of paper, but don't ever tell me that I don't. I'm not a lobbyist because in my heart I am a lobbyist, and people look at people who have letters behind my name. My employer is very nice and very understanding, and I hope I do a good job for my employer. I hope I'm not a token. I know I'm not a token in my employer's eyes, but if we didn't have if my employer wasn't what my employer is, and some of you know who my employer is, they could hire someone else that has letters behind their name, and they will overlook me, and that's not fair, because I think I do a good job. Maybe I'm fooling myself, but I think I do a good job. And why do I need letters behind my name? I guess I do because nobody believes that I can do this. Nobody, except people around this table and others. So I think the 4 things are plumbing, transportation, education, and employment.
What was that last thing, Liz?
And employment.
Thank you. Very good. All right, Hillary, Emmanuel, Joe, then James. Hillary, please.
Thanks. Let me try to lower my hand now, otherwise I'll forget and confuse everyone. Oop, did I go to, okay. So I'm just going to talk about like a few different topics. Well, first of all, thank you so much. This has been a wonderful event, and I really regret not being able to be there in person. You know, being a caregiver and of people with disabilities, sometimes, you know, your caregiving responsibilities win out. So maybe another time I'll be able to come in person. But so I just want to talk about a few things. A couple are kind of things that jumped out at me. And then can you hear me okay?
Yes, we're hearing you fine.
Okay, sorry, I thought it was freezing for a sec. Anyways, I'll just get going. So I think for it's hard to balance kind of the big broad topics with the specific details and balance that in reports or just kind of presentations too. But, you know, it's really challenging to hear, you know, to have lots of discussions about what HCBS services could be and how you could use this or how you can use that, when the reality is it's not accessible to like there are hundreds of thousands of people on a waiting list. So I would love sometimes to be more like solution oriented of, you know, kind of dealing with the fact that we have hundreds of thousands of people on a waiting list before, I don't know, just talking about kind of like pie in the sky type things or new developments. It's like just try to deal with some of the issues that we currently have. I also was somewhat, I mean, all the presenters, it was such interesting information, and I learned a lot. And having, being a lawyer, I certainly appreciated some of the presentations from that perspective as well. I was kind of struck by, technology came up a lot, a number of presentations, which is great. I want to see that technology discussions for people with IDD includes AAC as part of that, augmentative assistive communication, or whether it's not going to fit there, fit somewhere else, because it's a basic human right to communicate. So if we're going to have technology as a focus of things in the future to come for people with IDD, to be fully inclusive of everybody on that like large spectrum who has IDD and has differing abilities, challenges, whatever. I just really would love to see kind of more of pushing, a basic right to communicate is having access to AAC, being able to learn, being taught by appropriate, therapists to learn or other teachers, and that this shouldn't all just be happening in the classroom. This should be fully accessible to adults. And, obviously that would require teaching of DSPs and all of that. There's a lot of work there, but again, it's a basic right to communicate. And I just would like, I don't know, somehow to tackle that at a bigger level. And then the last thing I'll say is, well, I agree with Paul about the abuse and neglect. I work at a protection and advocacy agency. I'm a lawyer there. What I see day in and day out is very hard to deal with at times. And I'm just the one like observing it. It's not happening to me. As I'm not the one being abused. So, perhaps that is a good topic for a report. But, Paul articulated a lot of reasons. I'm not going to repeat them. I just agree it's an enormous problem that impacts the full range of people with intellectual and developmental disabilities, different functional levels and support needs. But the final thing I would say is future planning. There was a wonderful presentation and some discussions on that. Again, I just, come back to like, if I would love to be very like solution oriented with that. And, it's like, oh, it should be person centered. It should be, talking about the transitions for this, but like, what does that actually look like when we have such difficulty providing, residential solutions or options for somebody who really requires total care, and their parents have been doing that their whole life. Like the problem, I guess it's just that I would like to get a little bit sometimes more concrete into how do you really work on solving these problems, because relying on, I'm a sibling and I want my brother, I don't know that I'd be able to have my brother live with me and provide him all the care that he needs. And should that be what we as a society expect as care for our citizens who require that level of care? And I just have a lot of feelings about the
Thank
future.
you, Hillary.
Just
Thank
wanted
you.
to bring that up. Thank you. I was a little scattered.
We took note of many of your items, all of your items. So thank you. Thank you. All right, Emmanuel, then Joe, then James.
Thank you so much, and again, thank you everyone for welcoming me with open arms. Just a couple quick points I want to make. First, I agree. I think there needs to be a unit when dealing with abuse. However, I think it needs to go beyond the unit for responding and reporting, etc., etc. There also needs to be a unit within the justice system. We heard a report, can't remember if it was yesterday or today, about IDD counts. But I'm thinking about individuals who may be in imprisonment that have IDD that don't always get the right representation. A lot of you are uh, free lawyers, because I can't think of the public defenders. Public defenders have knowledge in law, but not in disability. So that's one of the areas that I would suggest we look at. I apologize that I don't know all of the components of the report. I'm hoping to look at the report that was done for HCBS, just so I can become familiar with that part of it. But also mental health. I know we briefly talked about mental health and the need for mental health services as a trainer and a program that we used to have here in Delaware called Stop the Abuse Now Delaware. Mental health is crucial. You have the trauma from the event, and then you have the time that it takes to process and come to terms with that abuse. But I also want to highlight abuse is not always sexual or verbal. It may also be financial exploitation, things of that nature. So if we're going to look at abuse, which is only one of the ideas that we came up with, I would suggest looking at all the 5 common types of abuse, but really taking a deeper dive look at the mental health. And the last point I'll make, when we talk about caregivers, I understand that we talk about siblings and DSPs, but I also think there's a number of individuals who are married, where the wife or the husband becomes that primary caregiver due to the shortage. I can't remember the last time my wife got to be my wife versus my caregiver. So if we don't fix it, the number of divorce will start to skyrocket, because not that people don't love each other, but they're only human and they can only take so much on their shoulders. So I would want to include, if we were to look at that we would also look at those numbers as well. Maybe some kind of survey to capture, how many husbands or wives are taking the lead to provide care to the person that they said I do to. Thank you so much.
Thank you, Emmanuel. Joe, then James.
Hi, everybody. Thank you. And I could tell you from somebody who has experienced an in-person day and a virtual day, the in-person day is far, far better. Listen, it's also nice to hear 2 days of discussion that's led by the people who are at the center of impact. And those are the people on this committee who have disabilities. And kudos to ACL for having the wisdom to make sure that the majority of the composition of this committee is people at the center of that impact. So good to you. I also feel that you really set us up nicely. I see what you did there. You set us up nicely with all of these presentations. You gave us the information. And with that information, we have to make a decision on what the next report will be. I believe that the topic of abuse and neglect, and thank you, Emmanuel, I would take it one step further and add rights violations, human rights violations, human rights restrictions to this idea of a real deep dive into how people with disabilities 25 years after the Olmsted decision continue to be segregated, institutionalized, abused, and exploited. I think we need to rip that Band-Aid off and expose this dirty, rotten system as it is. The data is compelling and the data is terrifying. And we can also, I'm sure, connect some strands in there that includes, once again, for the third report in a row, things about the workforce, because when you take a look at the data, who's doing the abuse and the neglect? It is the workforce. What can we do to correct that? So I thank you for this opportunity, and I really am thankful that I have 2 more years to be part of this discussion.
Thank you, Joe. Thanks very much. We're going to hear from James, and then we'll hear from Jordan next. Oh, and Kathy as well? Yes, okay. James, Jordan, Kathy, and then Chairman. We're going to hear from everybody, which means a little bit shorter, everybody, a little bit shorter.
I've been thinking about the last 2 days. The people in this room, from the visitors to the agency people and to our board and committee. The bottom line, we need to think of others who in different situations, living experience. Some live in the community, others live in a group home, others live in the institution. And people are waiting for services. Some got the waiver, or what type of waivers in their individual states. I'm thinking about people like I know many others don't have an opportunity, especially those who are living in institutions. People are wasting away. People put low expectations onto them. And even people in the group homes, people put lower expectations onto them. Oh, this person can do this. The mind's so closed, not to let them dream big. Everyone can get the right kind of support to be successful in the community. Instead of be in a large building or a town just for people with disabilities. I reflected my years. I've been doing this work a long time. I think we need to get the youth involved because their perspective is unique too. Because it's great to have Liz and all of us, all the self-advocates in the room. And I'm so glad we have some young people in the room today. Because if you asked me back in 1995, when I did something with the President's Committee, we didn't have any young people in this room. The other thing is important is that parents cannot live forever. We need to help and plan ahead when someone lost a significant other. I like Paul say about we need to hold people accountable about abuse and exploitations. As a sexual assault survivor, I was lucky to have friends who support me and get the support I need. But at the same time, we need to challenge adult protective services and to help us to be safe in the community. Don't pick and choose what crisis is the most important thing and the least important thing. We need to help each person when they have to deal with a situation.
Thank you, James. Thank
And
you. I'm sorry. Oh,
it
I'm sorry.
just makes me mad that people is just wasting away and states who not want to do any one damn thing about it. It's just so embarrassed when I say I'm from Texas that people, it's just the legislature is not doing nothing. The state agency do nothing. I feel like the federal government need to step in and tell people it's hurting and abuse and exploitation, and also to cut the waiting list down. It's a joke, and it's just very emotional to me. See my peers, over 240,000 people are waiting for services in Texas
they're so invested in the institution, but don't look at the people. And I want to first try to invade Texas and tell them they're all wrong. They're doing the way of the dual system. And this is my passion voice. I'm not angry. I'm just
We hear you,
sick and
James.
tired.
We hear you. Thank you. We hear you. I'll take a second here. All right, so here's who I have to speak. Jordan, Kathy, Lucy, Tia. Okay, so Santa, we're going to come back to you. All right. Jordan.
I really want to echo what Hillary said about AAC. I also recognize that it's hard to pick an area. For example, I really appreciate the ideas around abuse and neglect. It's a huge issue, and how can people who do not rely on speech, report, or engage in this discussion without access to effective communication? Trust me, when people are non-speaking, we still feel strongly and know what's happening. And the stats of abuse and neglect, when someone is non-speaking or cannot rely on speech, the data is even more grim. I just think there's some strategic ways we can maybe approach it, where if the report is more narrow, we think about some of the things that must happen first or simultaneously.
Thank you, Jordan. Thank you. Kathy.
Thank you. Boy, I think I used the word sobering yesterday. I'll use it again. What a couple of days. I think you asked us for some takeaways. And I
Please.
think the takeaways for me are the things that I knew, but now they're times 1,000. So when you think about the DSP, and I'll use air quotes, and I shared with Jim yesterday, I remember him saying on one of our calls that it's a farce because just, a direct support professional, the word professional is not reflected in any of the ways that we have positioned these people, whether it's training, whether it's pay, whether it's anything, yet we rely on them to care for our most precious resources. And for some of them, they're our kids. I would throw that in as a root cause possibly for the abuse and neglect. So I think when we start to look and if we zero in on one issue, I bet you we're going to be able to factor in so much of what we've talked about over the last 2 days. And so the abuse and neglect for me, this was the other thing that kind of, I know it's there, but I don't think, when I think of my own children, I would hate to think of anybody thinking that my husband and I have been neglectful for 33 years, doing nothing but pouring everything that we have into them being safe. But the reality is we've relied on people that aren't trained to be with them. So that is neglect. So I have a 33-year-old son that for the first time has had a year where he has had someone as a direct support professional truly helping him to be the best that he can be. So is that neglect? It sure is. It's absolutely. And it's not, I don't think that, again, I don't think I've been neglectful, but I think as a society, we've got to put that into the abuse and neglect, because if you're demeaning someone and you're squashing their ability to be, then that's abuse and that's neglect. And I'll just say, I would repeat what I said yesterday also. I think that we need to figure out where there are models of doing things well. And we have to, I think our group could provide a platform for really truly shining a light on those and spreading them throughout the country and figuring out how to share those pilots instead of leaving them in a pilot that we talk about from 10 years ago. Thank you.
Thank you, Kathy. Lucy, then, oh, yeah, Jim. Okay, yeah, that's great. So Lucy, sorry, Sean, we've heard from you, so we'll have to get through everybody else. Lucy, Tia, Santa. Well, I know you want to. If there's time, we will. Lucy, Tia, Santa.
Okay, my name is Lucy Maya. I just want to say what an honor it is to be here. I couldn't agree with everybody anymore. I do. Disability is so important to me, to my family, to so many of my friends. We just can't take anything for granted. We have to appreciate everything, and take care of everybody and know who can, who needs help and who doesn't, and we need to help as many people as we can.
Something else you want to say, Lucy?
I can't read that.
You had good luck with Special Olympics and Best Buddies.
And thanks to Special Olympics and Best Buddies, I now have more friends than ever before. More friends, who take care of me, be with me, fly to Vermont and stay with me, help me do all my physical therapy with me,
Thank you.
and doing everything. And it's just simply incredible. So I
Very-
just want everybody to have the same opportunities that I'm able to have and my friends are able to have every day.
Thank you, Lucy. All right. So Tia and then Santa.
Yeah, first I want to say thank you to everybody who helped us finally meet in person. Yay. We've been waiting so long. The first part I want to talk about is a little bit about the meeting. I know you tried really hard to make this really accessible and great for people, but to let you know that people don't always have money to dish out ahead of time and wait for reimbursements 2 to 3 weeks later. It's really hard for people. Other times also people here don't have credit cards to put down in hotel rooms. And I know you went back and fixed some of that, but just to let you know for ahead of time, in the future, if we meet again in person, some of those things need to be taken care of. The other thing that we talked a lot about abuse and neglect, and I agree with everything that's been said here, but also people with disabilities don't have a lot of opportunity to have sexuality training. And they're wanting it and they're asking for it, but they're not being able to get it. And that's an opportunity where maybe some of this abuse and neglect could be prevented ahead of time with people being allowed to have sexuality training. And then also, if there's a great, people were also talking about how to be included on like boards and committees and things like that. There are some resources that are out there. One is Listen, Include, Respect on how to include people in meetings with intellectual disabilities, because they do it really well for people with, sometimes do it really well for people with physical disability to get access, but not intellectual disability. And the other one is Beyond Tokenism. And that's some video stuff too that that people might be interested in looking at. And we need more stuff like that to train people on how to include people with intellectual disabilities in jobs, in projects that they're working on, in committees like this, in boards. People still need training on a lot of that issue, on those issues.
Yeah, thank you.
Thank you.
Santa?
I have a couple of questions. No. I think if we are going to talk, I think if we are going to talk about Bruce, we have to talk about advocacy. many people who they don't know what abuse is. They don't know how to I think about more, no, I think about people who need a lot of help, like me. But I know about abuse. I am able to see, no, to see, think, no, see, teach, no, teach. I am able to say that's not right, but I know so many people say who are friends, no, are I am afraid. I'm afraid. I'm afraid of. I'm afraid of to say anything. I never say no. Oh, I never say. I want to. I wanted. No, not to say. I want people who are. Oh, I wanted people who are getting older to understand what's going to happen with their bodies. My body is so different than when I was young. And no, nobody ever told me about my body. And I think that's important.
Thank you. Thank you, Santa. Chairman, we'd like to hear from you.
First of all, let me just say that in the last day and a half.
Is your mic on, Jim?
I must say I'm sure I'm being timed, Robin, so I'll be brief. I know the clock is ticking. Let me just say in the last day and a half that I have been impressed and I have been inspired by the passion that each and every member has brought to the table here. That I've often said that anytime I go to a disability meeting, I think of my brother in the sense that there was no one advocating for him when he lived. He was on his own, And I made the commitment that whatever disability meeting I'd go to, I'd remember my brother Jacks of the world that have no voice. And all of you came here, not for yourself and talking about what your life is like. You talked about people who weren't here, what they're going through, and the barriers they face day in and day out. So I learned a lot. There were issues that I didn't know that much about, that you gave me more meaning, and I appreciate that. I'll also say, I think the report that we did, 2024, is very good, but it's broad. There's a lot of items in there. And some of them are just repeats that have not been acted upon, and we're urging people to act again on them. I think going forward, I think we have to be very narrow, but deep. And it could be 1, 2 issues, but I think it should be narrow. And I've heard an awful lot about abuse and neglect. I think there's an opportunity to highlight that, because I don't think there are people outside this room think that's a big issue. It's a big issue. My other hat that I wear, and very proud to be the chair of, in Massachusetts, we call it Disabled Persons Protection Commission. What is it? It's an agency that reports all abuse and neglect. Any citizen in the Commonwealth of Massachusetts can call a hotline number and report an abuse. And we have investigators that will look at those cases, and then they will determine whether they should be prosecuted or not. That number is going up all the time. We average 1,000 calls a month. I don't like those numbers going up, but it's a reality. I don't know, maybe it's a monumental task to kind of create a national adult protective service abuse reporting hotline. But it might be worth exploring. There are some models out there that you can look at, i.e. Massachusetts is one of 3 or 4 states that have that in place. But the point is, I think it's something that should be highlighted with the citizens outside of this room, that abuse and neglect should not be tolerated at all, and that all people should be treated with respect, and that all people, and I mean all people, have rights. And some of these individuals that are living in our communities, their rights are being violated. And I think there should be a vehicle to address that. So I'm in favor of creating some type of, I don't know if it'd be a hotline, but we don't have a hotline nationally that I'm aware, although I think they just passed one on mental health. I think Congressman Moulton has something similar to a mental health hotline that you can tap into if you want. So it's just an idea, but I do think our report should be narrow, that we don't need 5 or 6 issues, because you do that again, gets lost in the shuffle, and people go, wow, that's a comprehensive report, but quite frankly, I don't even know what's in it now. It's so much. Keep it narrow and keep it deep. That's my only suggestion, but.
Thank you, Chairman. Thank you. So I understand Brent in our meeting room wants to share a thought.
Yeah, I'm in agreement with them pursuing abuse and neglect, and just suggesting that if we go in that route, I think Maine Justice convened a focus group on IDD in 2021. It'd be good to have people from that focus group come out and talk about it, and people from the Criminal Division, the Civil Rights Division, the FBI, and the Office of Victims Crime present to the group on those issues. I think one of the main hurdles in going on that route and dealing with it, at least from the criminal side of things, is that it's a local crime. I don't believe that there's a federal statute that deals with physical abuse, economic abuse, sexual abuse of people with disabilities. I think you have to shoehorn it into a hate crime statute. So that's something to also look at, encouraging the creation of federal criminal statute to deal with criminal abuses against individuals with disabilities. But I think that's a great route to go.
Thank you. Thank you. Kara?
That point all of people that people they say I'm well I say people want me say that's a moment go help somebody else. So I like to help people who don't understand. For me, my apartment and well.
So you like to help people who don't understand?
Yeah.
And people sometimes don't understand you?
No.
No. Oops.
They say I have a big mouth, so you need to go help somebody else.
Who said that? She said they say she has a big mouth, so she needs to go help somebody else. Who said that?
No.
Who?
Probably people.
Oh, some people who are advocates along with you?
Yeah.
Okay.
One person there.
Okay. Well, he's teasing.
I know, but
Okay. What about the meeting today?
I like it. Even though it oh, even though my mom we will fight because he has given me Christmas stuff.
Right. Her brother had to help to get her dressed at 6 o'clock this morning. But we're here. What did you learn?
I learned
real quickly.
back, tell people know this is what I learned.
Oh, to report back to other people?
Yeah.
Right. That's what we should all do.
Thank you. Thank you. So it's time for summary statements from Jennifer and Jim. A look at next steps. Please.
Well, I also want to thank all of you for all your hard work, not only over the past year in the report on HCBS, but also over the past 2 days. We've made a lot of comments about how much was covered, and I've been impressed by the attention and commitment that you all have had to each of the topics covered. And it's quite clear that we could have spent an entire day on each topic. But we did want to just cover a number of areas to give you, as I said yesterday, food for thought about the topic for the next report. And so in terms of next steps, that will be the focus is further work and discussion on that topic for the next report. And in doing so, we will definitely be coordinating and getting input from you all in terms of how best to do that, if that involves hearing more about one of the presentations that we had, getting more information on particular topics, and we will explore with you how best to facilitate the process of identifying a topic for the next report. So we will be following up with details for meetings to follow, but that's in general what the next steps will be. But again, thank you very much for your time and your commitment and for being here. And Jim, I'll turn it over to you.
Jennifer just about said everything. I just want to thank all of you for taking time out of your very busy schedule to be here. Thank you for your input. Thank you for your patience. Kudos to Robin, who did an outstanding job, to say the least. And not an easy assignment to be given. And she's done it with grace. And I really appreciate all that she has accomplished. You get your hand up, John, because you did. Yes, sir. I'm in the middle. I'm the chairman. I'm in the middle speaking and you're interrupting. Huh? Yeah, that's okay. That's all right, Sean. That's all right. Go ahead. What do you want to say?
When is the next meeting so I can present on my calendar?
Yeah, we don't have that date yet set. But what we want to do is identify what will be the purpose of that next meeting. Again, will it be to have further discussion or get information maybe on specific topics that were presented? So it will want to do that follow-up with you all and then set that next meeting.
In person, I think down the best more connection and we.
Yes. Wanda? This evening.
Wow.
That's timely.
Well, again, I just want to thank all of you and Wanda and so many people who have been involved. But can I just give a personal shout out to the gentleman to my right? David avoids the spotlight, and the past 2 years has been very difficult. You know, this is my 7th commission that I have been privileged to serve on. And this is the most difficult one only because, as John alluded to, we weren't meeting in person. Nobody got to know each other. And it was just very difficult. It was all Zoom and telephone calls. And to be able to do what we did, I think is remarkable. And to put together a report like that is extraordinary. To do it all in the time frame that we did says an awful lot. But David never took his eye off the ball. And he was really, truly the person behind the curtain who did a terrific job. And I know he avoids the spotlight, but I just want to say congratulations. He reflects well in the agency, and it's been a joy to work with you and continue to work with you. So with that.
That's very nice.
The recording of our meeting, the PowerPoint, the minutes will be posted on PCPID website at the end of October. So with that, I just wish everyone a very happy weekend, safe travels, and I will now adjourn this meeting.
Thank you.